Look what I did to this city with a few drums of gas and a couple of bullets.
The overarching theme of the Joker is that he is really a psychopath. So a psychopath is someone who's callous and uncaring. They will use people as pawns to get what they want in their lives. They really don't care.
I feel like listeners or viewers might hear your definition of that and be like, oh, I dated one of those.
Yeah.
Is that...
I've been asked this before. When it comes to dating, psychopathy is probably an extreme version of narcissism. One of the traits for narcissistic personality disorder is you lack empathy. I think they're talking about people who are totally absorbed with themselves, not considering other people, think they deserve the best treatment. They should be the center of attention. They're pursuing unlimited power, beauty, money, whatever. Those are narcissistic traits, and maybe you are seeing them in people you date. Are you displaying them also, or what's happening?
Welcome back to the Checkup podcast. Today, we're diving into the world of Dr. Eric Bender, a psychiatrist whose insights on the human mind have been featured everywhere, from the New York Times to viral videos with GQ. He's not just a doctor, he's a storyteller who makes the science of mental health actually click. You may have enjoyed his work on Batman Arkham Shadow, where he served as a consultant to ensure the science was spot on. In this episode, we're diving into the surprising ways Hollywood gets mental health terribly wrong, where it nails it perfectly, and even into the social media trend of diagnosing your ex with a personality disorder. Trust me, you'll walk away from this one seeing media and even your own mind in a different way. Let's get started. You've become quite vocal about how mental health is portrayed in media. If you had to say positive, negative, neutral impact on your work day-to-day working with patients, how has media impacted them?
Media impacts them tremendously. YouTube just took over as the most watched from other streaming services.
Yeah, let's go.
So people watch media, and whether that is YouTube or whether they're watching Netflix or whatever other streaming services, people get ideas from media. If you look back, I'll just remember some of stuff from when I was a kid. The Karate Kid, 84. Karate had a huge explosion in popularity. And you go back farther, 75, Jaws. Sharks were suddenly hunted a lot more. Media gives people ideas. So to get ideas about mental health, let's make sure they're good ideas or real ideas.
Yeah, that's true. So how, if you're doing a report card, do you think it's been trending on the good side or been more problematic?
I think it's going in a very good direction. Okay. When I first started doing work with media and mental health, it was back in 2008, 2009. And at that time, I had teachers telling me, why are you doing this? This is a waste of time. I was asked by ABC News, can you talk about Darth Vader? What personality disorder Darth Vader might have? So I was talking about borderline traits and histrionic traits with some colleagues. And one of my teachers I really liked, he's like, does Darth Vader borderline personality? What? That's so stupid. But it's not. It's an entrance to talking about mental health, which even though we're going in a good direction, it's still very scary for people to talk about. So if we can talk about characters in movies and TV shows they like, then they can start asking and learning more.
I always worry when talking about mental health subjects or covering them, there's a way to talk about them responsibly where you are pointing out that this is not the normal way that you would go about diagnosing things, but you're doing this as a form of entertainment in order to educate. Yes. Sometimes people blur the lines of that. Have you seen that happening a bit?
I have. I think if I'm looking at, just to be clear, do you mean people looking at a TV show and saying this is how it's done and this is how I expect a psychiatrist to be?
Well, maybe we can talk about multiple avenues here. So the classic example is you see someone on television, perhaps a reality TV star, and people start diagnosing them. Yeah. I mean, I get calls like that from trash outlets all the time that are like, oh, hey, do you think this person has borderline personality disorder traits?
So that's a great question. So if we start with that place, I'm often asked, what do you think of this person, this public figure, this political figure, this actor, this actress, you name it. And I always say, I haven't evaluated that person and I don't have permission to talk about that person. I'm not going to comment on that. There's actually a rule. The American Psychiatric Association has the Goldwater rule, which dates back to when Barry Goldwater was running for president. Psychiatrists were surveyed from Fact Magazine, or Fact Magazine sent out a survey to psychiatrists, I should say. And about 1,400 responded saying Barry Goldwater is not fit to run for president or be president. They'd never evaluated him. They had no knowledge of him whatsoever. And American Psychiatric Association came out with the Goldwater rule. You cannot talk about these people that you don't know unless you have evaluated them and have their permission. Fact Magazine was sued and actually went under after that. But yes, I can't talk about ethically people that are in the public eye.
And yet it somehow still happens. Why and how does that?
I think people, there's no doubt people are fascinated by what is going on. Why is this person acting this way? Why is this person doing this? Do they have something wrong with them? I think it's natural to ask those questions. I think some people maybe aren't aware of the ethics. Some people don't mind stepping across that line because maybe it brings them something, some joy, some fame, something. But I think it's natural to wonder, but it's also, there are ethics here we should pay attention to. Are these rules in place because it's ethically, morally wrong, or because you can't actually know what's going on from your limited knowledge superficially? I think both. And also you can do a lot of damage to people by saying, oh, this person is this. Clearly this person is this. You have no idea. Or this person's doing this. You can talk in generalities. I could say when I see behavior where someone might do this, I think there could be these kinds of things going on. So I'm not diagnosing anybody that way. I'm actually giving more information and using it as a way to teach. But you have to watch when you're doing media interviews because you can get clipped where suddenly they're saying it. And I'm sure you've had that experience where suddenly you're wait a minute, that's not what I said. Yeah. And this actually happened to be a point of prominence 5 years ago on YouTube, maybe a little longer, where people started labeling one of the Paul brothers. Was it Logan Paul or Jake Paul? So a sociopath. Oh, was it Shane Dawson? So basically there was someone who was doing content with Shane Dawson in the mental health space saying that these individuals are sociopathic and essentially making the diagnosis without truly knowing them. And to me, again, from just trying to be factually accurate, throwing the ethics and morals out of the equation for the time being, people on camera turn up their personalities, change the way they act, especially when there's viewership involved, money involved. So to judge and understand them as a whole person feels like you're drastically not getting the whole picture. Correct. And that's the way I look at it too. Yeah. You don't have the whole picture. I had a conversation with my wife a few months ago. She said, do you realize how much power you have as a psychiatrist when you're telling somebody how you see them and how you understand them? And I do. That's why I don't say certain things. That's why I'll help people explore what's going on in their lives. I don't want to label people with things, and especially people I don't know. That's just, it's not ethical if we bring that back in, but also it's just, who knows what's going on. Yeah. What about from the standpoint, if you're talking about a fictional character, does the ethics then resolve and the accuracy is less important? These individuals have not existed and they're great teaching tools. And it's a great way to start conversation about mental health. Now, when I first started, again, people weren't necessarily open to this. There were some major comic book characters that colleagues and I looked at. And some of the people behind the characters were like, why are you doing this to us? Almost thinking we were taking away millions of dollars because we're criticizing. That's not the case at all. You can actually have more psychologically deep characters, and they're even more appealing to your audience. So people weren't always open to it. Why weren't they open to it? I think they were afraid of what would happen to our characters if we have to change this. If these guys, these psychiatrists, these doctors, these whatever are telling people this about the character, what if we change them? But there's been a huge change over time. I mean, now I get calls about, hey, can you add psychological depth to our characters? We don't want to do this show, video game in the wrong way. We don't want to do anything that's stigmatizing. What does it mean to add psychological depth to a character? So what makes somebody tick? Why do they have this kind of reaction with the world around them, to the world around them? How do they interact with people? What goes behind that? Why might they think this about someone? Why might they think this about themselves? So all the pieces of who they are and how that comes together to create a character, somebody just like us who is going through the world and interacting with the world in different ways. We're the sum of where we came from and who we are. Has to do with a lot of experiences in our lives. So it's understanding what experiences might make somebody like this. Do you think about a specific patient when you're doing this? I don't think about a specific patient. I think about the character. So I was really lucky to work on Batman Arkham Shadow. It came out in 2024 and I was excited. It got VR Game of the Year. And Camouflage, the company that put it out, that worked for Meta, they were so open to this. And what I would do is I would talk with them about the characters and what they wanted to show. And then they told me some of the story they had, and I could say, oh, if someone came from this kind of background, then this would probably happen. This is how they might see this. This is how they might understand their emotions. So it's not that I have a patient in mind, but I'm imagining them sitting in front of me. What can I understand what happened in their lives that would make them this way?
Is it always that like fatalistic, for lack of a better word, where if this happened, this type of upbringing, that means they'll develop in this certain way?
No, it's actually the reverse. I'm like, okay, this could come out this way. Like they're acting this way. I could see that this could be in their background.
Got it. Okay. So it's not always just a one-to-one equation moving in both directions. So then when we have fictional characters, isn't there ever a concern if people start seeing them being diagnosed as a way to scare them away from seeking help for their own mental health problems?
That's an interesting question, because one of the things that I remember most from one of the Comic-Con lectures I was a part of is we were talking about mental health in comics and TV shows. And at the end of the lecture, a woman raised her hand and said, when is there going to be a depiction of a character that doesn't make me feel like I'm going to be a criminal? When am I going to see a villain with mental illness that doesn't make me think I'm just going to grow up and be terrible? And I remember that so vividly. And I think the way I go about this is never to teach somebody, oh, don't be like Batman. It's more like, let's understand this. How is he coming to deal with maybe PTSD? Or how is he dealing with this? Why does he react so strongly to this? And I think that gives audiences little bits of themselves. They're like, oh, wait, I do that too. Oh, wait, Tony Soprano, he has a panic attack. I've had those. Oh, I could talk about that. Or, oh, Batman, he did this. Or Superman, he feels this burden of responsibility to take care of people. That's what I feel like with my parents right now. So it's just ways to people to understand themselves and see themselves in.
So it's probably good to do it with a variety of characters, not just villains, let's say, but heroes and everyone in between.
Yeah, and I think you've seen that over time, where it used to be all the villains, the tropes were, oh, they were neglected, they had this, and they became this psychopath and this. Now you see anti-heroes more, like Don Draper from Mad Men, or you would see Tony Soprano. You'd see these people that are borderline good, bad. It's not just a villain. And then you see heroes that are struggling with things. And I think that's really important. I mean, look at Superman, lost his parents in Krypton, and he's here to take care of a human race he's never going to be a part of. So there's huge psychological weight there. So we can talk about that and people can understand just more about themselves.
Yeah. Before we get into psychoanalyzing Batman, because I want to do that and more.
Yeah, sorry.
No. That's really good. The third part of that conversation of when media starts doing psychological coverage of, we started with nonfiction, then fiction. Then what about when they're in a fictional program depicting what therapy is like or who needs therapy? I feel like that's the third section of it. Do you think that has been portrayed in an accurate light?
I'm trying to be responsible for making sure it's portrayed if I'm asked about shows or movies and comic books. But yes, I think it's getting better. I think The Sopranos did a great job with that, with Dr. Melfi, and what it was like for Tony Soprano to come into therapy and develop this relationship with somebody. I think there are a lot of shows that are doing it really well. I also think if you've ever watched a 0-0 baseball game, some people are really bored of that. They're like, oh, there's no scoring, there's nothing.
That's why people shit on soccer all the time.
Yeah, exactly. Same thing. Yeah, that's it. We'll take soccer. People are like, oh, this is boring, but there's so much going on, and therapy's like that too. There's so much going on in the moments where there's not a Goodwill Hunting moment,
right? That
I think people don't want to necessarily see that, and that takes time. So a TV show is limited to a certain amount of time. You're not going to show therapy unfold the way it would.
Yeah,
but you can take elements of it. I think it is getting more accurate. I think it's being depicted
Any
better.
Particular bad examples of therapy that stick out in your head?
Bad? It's not that I find them as bad. It's just I'm like, oh, I wish they'd done that a little differently. Mm-hmm. So I think I'll give you a great example of where I was really excited and I thought, oh, they could have even done a little bit more, was Never Have I Ever, Mindy Kaling's show. I thought it was great. There was a bunch of adolescents. One of them was seeing a therapist after the death of a family member and had been seeing that therapist for years. And it was really great, because that doctor had an understanding of adolescent behavior and understanding how this teenager might have seen herself. And the teenager went to that therapist repeatedly for help and guidance. But there were a couple of things. I think it was a comedy. Like she would break into the office, kind of like bust into the office when the therapist was having lunch. And there could have been a patient there. Like people just don't do that. So there I was like, oh, this is great. But and then also there was a time when the therapist hugged the patient, and you're not going to touch your patients in that way. But again, I love that they showed an adolescent needed help.
Are hugs unethical in the psychiatric
It's not unethical. It's individual, but I would say I've had some teaching that once you touch the patient, the relationship has changed. Now, I will touch a patient because I'm taking their blood pressure or something like that, or a handshake, something like that. But a hug, to me, in the way I was taught, is like that's a little much. So I've had patients ask
in the time that you were being taught this, what were they saying, that the patient then attribute something different to the relationship?
Yes, there are certain boundaries in psychiatry, and they call that the frame. And you have to think, why are you breaking the frame? You always have to understand.
Tell me more about this frame.
It's the frame refers to the boundaries you have with the patient, and they're in place to help the patient. So you wouldn't go out drinking with your patient. You are not your patient's friends. They need somebody who can be objective, somebody who can see them in a certain way, somebody who can understand them. And when you do things like that, there starts to be meaning added into something. So if I brought coffee for my patient every day, there's something more in there for that patient than maybe just the coffee. It's like, oh, this person's thinking about me in an extra special way. I must be their favorite patient. Then there might be a pressure on that patient to be like, I need to be extra good. Like, what if he stops bringing me coffee? Like, if I don't bring it one day, then somebody will be like, am I bad? Like, there's all kinds of things that can get read into this.
It basically becomes another place for cognitive distortion to creep in. Yeah.
Correct.
Interesting. But how do you maintain like a healthy, happy doctor-patient alliance while maintaining this very strict frame?
I think that's the art of medicine when it comes to psychiatry. If you're doing therapy, is how do you do that? And what I will say to patients is when they'll say, I wish I could be a neighbor. I wish I could be your friend. I'll ask them, what would that do? What would that be like if we were friends? And if you imagine that world, what do you imagine? Because I want to know what it is they're getting out of that. So I'll explore it. I'll also say, that there are boundaries here for a reason, because I need to be someone that is different from everybody else in your life. It's also just a unique relationship to be in therapy with someone. And our relating this way, our relating the way we do, the therapy happens here, and all the feelings you have, you take outside. So more therapy happens out there. And our time is just this hour, 2 hours, 3 hours, 4 hours a week. And I want to see how you're reacting to that.
Yeah. Have you heard about this case that's, it's not even a case, probably giving it too much credit, on TikTok going viral, of an individual sharing what she describes as a relationship that has formed with her psychiatrist or psychologist. And she does this like multiple series of TikToks sharing this story about why they're interested in her. And the internet is like really interested. Is she making this whole story up? Is this fictional? Is she sharing her real life? And no one really knows. And because of all this curiosity, it's garnered a lot of attention.
Interesting. No, I haven't heard about that. I'd be interested to learn more. What I find is, if you think about your patient and what your patient needs, generally that guides you pretty well. So that comes to, when it comes to self-disclosure, talking about something about myself, it's because I have the patient in mind. I think they can learn something from it. I shouldn't be filling up that space. I don't need my patients to take care of me. And if they ask me certain things, you don't want to be weird. So if people are saying, oh, where are you going on vacation? I might say, well, I'm going to go here to the East Coast. I'm just going to go visit some family. But I don't want to give them details about things, because it's not for them to think about. It's just for me to think about you.
Sure. So in the past history of examples of therapy, of seeking psychiatric help, there's some movies that come to mind, The Beautiful Mind, a lot of very powerful Academy Award-winning movies. Do you think that they've given people an accurate representation of certain conditions? Or do you feel like because they're trying to suspend reality and allow everyone to understand and have buy-in, that they've lowered the accuracy level to a degree where it perhaps becomes a bit harmful?
I think you can have a wide range of consequences to how things are depicted, and there's a wide range of how they're depicted. So I think, for instance, Silver Linings Playbook is a movie people really love, and the depictions of bipolar and mania I've commented on before. I think there are some great scenes. The knock on that, for instance, is that love in the end will cure mental illness. And that's not actually accurate. But you take away from it what is accurate, and then you can talk about, wait a minute, does it really work that way? And hopefully you have somebody you can talk to about that. But love is not going to cure it, but love and connection is really important to getting through life with mental health issues and even without.
Yeah.
So I think you look at things, if it's doing a disservice, that would be saying, for instance, let's show a treatment that's very effective and let's make it look horrific. Like, I think that does a disservice, because then people are like, I don't want to do that. That sounds horrible.
Right.
So I think that can do a disservice. But if you're starting to show mental health on screen, I think that's a first great step, because for so long it was just not something people wanted to see or people were afraid to show. I think it's great that we can show it more nuanced, because I do think it's more interesting for audiences, and I think it's better to be accurate.
What about individuals self-diagnosing or perhaps discussing their medications, their therapy styles on social media? Because I think about one of the problems we discuss in the medical side of things is direct-to-consumer advertising with pharma. And these days I'm like, yeah, that's a problem, but I feel like it's less of a problem now, because the things that go viral are not direct-to-consumer ads. It's the things that give social proof. So someone making a very passionate plea of everyone should be on this medication, it saved my life, and really going to bat for it, perhaps can be a disservice, way more effective than any direct-to-consumer advertisement from pharma. So what's your stance on individuals making videos like that? Do you generally discourage it in your patients, or is that not something you cover?
I think again, anything that gets the conversation going, great. However, there's so many complexities to medications and treatments and responses. I think that people just need to realize that because this medication was great for this person doesn't mean it's going to be excellent for you. And I do have a lot of patients come and say, oh, I saw this on YouTube, or I read this on Reddit, and like, okay, all right, so you read it. What do you think? And so have a conversation and say, well, we've been over this before. Sometimes people will come back with saying, I read this again. Say, well, what are you trying to accomplish? What do you want to do? And we could try that. I don't know that that's the best way to do it for you for these reasons. So I think people can't come in with those questions. I encourage you to bring them to your doctors, talking to your audience here. Bring those questions to your doctors, but realize not everybody's going to respond the same way.
Yeah, because I think about how difficult it is to access mental health support, seeing a doctor, let alone in any specialty. But then they see some of their friends that are perhaps sharing their mental health journey, getting a lot of support. Does that ever start becoming addictive, perhaps contagious, where they're like, ooh, this person's getting support. Maybe I too am suffering with that. And they kind of see themselves in those people.
Yeah, I think
especially younger and more influential minds.
Yes, I think people can be influenced by other people. So in that case, it could be a good thing if someone says, hey, I've gotten some help and I'm feeling better. Maybe someone else is willing to say, oh, my friend did this, so yeah, I'm going to go try to get some help. So I think that can be good. Whether it's contagious might be too strong of a word, but the fact that we can actually have people say to each other, I'm really struggling with depression. I went to talk to somebody, it helped. Or I'm really struggling with anxiety and I don't know what to do. And then maybe their friend that they're talking to can say, have you thought about talking to a professional or talking to somebody that might be able to really help you? I really like when that happens. I really hope that happens more.
Do you think there needs to be a healthy balance between being comfortable breaking the stigma and sharing that you have a mental health diagnosis versus wearing it like a badge of honor almost?
Yeah.
Like, how do we balance that?
The way I look at that is mental health is a part of who you are. It's not everything. It's a part of your story. It doesn't have to define you. So how do you understand your mental illness, and how do you understand your mental health? And what does talking to other people about it give you? What are you trying to get? I think that's one of the big things with patients is, what are you hoping for? What are you wanting when you talk to people? And asking them, how do people respond to that? Are you finding they're responding well, or what are they thinking? And what do they tell you they're thinking? And then this can be something that we can look at, like, is this pushing people away to talk about your mental health or to talk about anything? Like you're talking about it, what does it do in terms of your relationships? So I think we need to look at each individual case and understand what's happening there.
Yeah, I've definitely seen a fair share of my patients, like, meaning that I've seen stigma be broken to some level on social media where people are more open to talking about their mental health journey. And I view that as a win. But then I also see patients of mine that have not been seen for some period of time. They didn't have insurance, lack of access, et cetera, end up self-diagnosing because they saw someone. So I'm trying to, obviously I would love for them to spend time with a psychiatrist like you and have the ability to reflect on these emotions. But knowing that many of them won't, what are some guardrails that individuals can have for themselves when watching content online?
I think realize you are who you are. You're not this person you're watching. And even though you might identify with them, you're still who you are, and you need somebody to see who you are and understand what you might need. So if you're self-diagnosing, it's good that you're taking an interest, but then talk to your doctor and ask them, this is what I'm seeing, this is what I think. Do you see this? Is there a way to figure out if this is a diagnosis? Often people will come to me and say, I can never concentrate, I have ADHD. I'm like, well, there's actually a lot to ADHD. So let's talk about what you're experiencing. Can I have your consent to talk to family members? Do you have old report cards? Do you have things that show there's actually a history of this? So I think you really have to spend time with your patients understanding what they're coming to you with. What have they been self-diagnosing? And they might be super excited to finally get help. So I want to figure that out. Or are they super excited to get a stimulant?
Yeah. So what do you do in a scenario like that where someone comes in and they kind of self-diagnose with ADHD and they are looking for a stimulant or believe that they should be on a stimulant, and you do the research, you talk to family members, you look at report cards, and you don't see that pattern evolve? What do you do in those
That's
scenarios?
happened a bunch. I'll say to people, I don't think you meet criteria for ADHD, actually. I think you might have more anxiety, and that's actually holding you back. And that the way your brain is going from one thing to the next is because of anxiety. Or I'll say, I'm not sure that this is ADHD. I think you might have a learning challenge here. And let's look at that a little bit more. There's a neuropsychologist I know that you might see, and they can do a lot more detailed testing, looking specifically at that. And let's see if there's something there. So I'll have a conversation. I'm not going to shy away from it.
Do they ever get negative about that?
Yes. There have been times when I'll say to somebody, you might have ADHD, but I think your addiction issues are what we need to address first. And let's have you see somebody who specializes in that type of addiction. Sometimes people get very upset. They're like, I came to you for ADHD, not addiction. And I have to say, I understand that. I also don't ever want to do my patients a disservice. And I would be doing you a disservice if that's what we're focusing on.
And you're very confident in going that route?
Yes, I am. And I don't mind people not liking me, because that's also part of being a psychiatrist, is tolerating how people feel. And I'm okay with my patients being mad. I'm okay with my patients being really unhappy with me, because I think that's part of being in therapy, having that space to be angry, to be upset.
I feel like psychiatrists then are the perfect profession to be on social media because part of being on social media is tolerating that experience of people being really mad at you.
Yeah, it's a good point. Yes. So it's a muscle I'm continuing to flex every day.
Nice. What's been your experience making some of these reaction videos, commentating on superheroes and villains?
Yeah, I feel really lucky. A lot of people have really loved it. They want to know more. If you think about your favorite TV shows and movies, you're like, oh, I wonder what's going on in that world still, or why did he get that way, or how did she respond, and why did she do that? Why did she have that relationship with her father? So when I talk about what might be there, people love it because it's their characters, it's their shows, and they want to know more. Every now and then I'll get some negative comments like, you're wearing the wrong glasses, those are terrible ties, that kind of stuff. But then the other thing that people really feel strongly about is certain things with treatments. Like, I would never offer that treatment. Why are you offering that treatment? You're a psychiatrist, you have no business talking about therapy. And that, I just have to tell people I actually sought out extra training in therapy. And just because I'm not a psychologist doesn't mean that I'm not a therapist. And I have other people say, you're a pill pusher, you're a psychiatrist. I can prescribe medication. I went to med school. It doesn't mean that's what I do the bulk of my day. So I think some of these I have to let roll off my back. And I think if someone really took the time to understand, they wouldn't have the negative comment. Or I think sometimes people have been really scarred by experiences. Maybe they had a negative experience with mental health professionals, or they had a negative experience, someone in their family had a mental health issue. So I always think this person's coming from somewhere. I don't know what it is. I just want to be here and I'll answer questions if I can.
Do you ever get the sense of, and someone just mentioned an example, I don't remember the example offhand, but I felt like two things were true at the same time that felt like they couldn't be true. There was two individuals speaking. One was an expert, I believe, in the mental health space, maybe a neurologist. And they ended up going down this pathway of, oh, did you do this in your childhood? Oh, did your mom do this while she was pregnant with you? And they went down this checklist. And he's like, well, that's why you're feeling this way. And my thought right away in that moment was, A, that's bullshit, because you're not really evaluating the situation. You can't know. And B, is it could be true, because there are some examples of maternal exposures and how they impact the development from a neurophysiological standpoint. So it's like, you need to have in your head, this is bullshit, but also can be true at the same time.
Yeah.
How do you feel like those worlds coincide in
I think, let me think of how to best say this. I have the belief that we really do see the world because of experiences throughout our lives. And a lot of them we aren't even aware of anymore. They're in our unconscious, but they've shaped how we go about interacting with people, how we see things. And there are times when you're speculating on that, saying, this did happen when you were a kid. What I'll say to people is, from my experience, I have seen people who had that experience look at the world this way. And I wonder if that resonates with you at all. But that could also not be true at all. So that's the way I handle it. It could be that. It could be something else. And people will tell me often, like, that would make sense. I don't feel that way. Or, no, that's not what happened. The reason this happened is this. And then they'll actually tell me, like, this is what happened. I think there's different ways you can balance maybe this happened, maybe it didn't. And a lot of the therapy I do is exploratory therapy. It's exploring what people have experienced in their lives and how does it affect them, and are they aware of certain things. And I'll see people sometimes for a while, and then they'll say to me, I haven't told you this, but this is something I've really thought about. This happened in my life. And I feel really honored that they feel so comfortable to talk to me. And then that opens a huge door where, like, that sounds really, really painful. And I wonder if that's been behind a lot of what you feel.
Mm-hmm. Yeah, I think about in the medical side of things, how I watch either like a house MD go down a checklist and make this miracle diagnosis. I'm like, oh, that's so not realistic. Or on the flip side, I see some influencer huckster that's like, oh, you have headaches, it's because you're not consuming enough pink Himalayan sea salt, some like wild claim like that. And to me, there's obviously various forms of misinformation there. But to me, what bothers me on a larger scale is that it's ruining people's understanding of how we actually go about making a diagnosis. So creates a barrier next time they go see a doctor. Has there ever been a patient where you've seen them come into either a therapy session or a medication visit? Maybe you don't even make that distinction when you see patients, but they are working off something that they saw somewhere else and they expected something completely different than what you were offering them.
Yes, I've seen it in many different ways. I've seen one patient start with me years ago, and they'd been in therapy before. And then they said, after a few visits, like, so this is therapy with you, huh? I said, this is how I work.
This is therapy with
and they're like, I have no idea what I was doing before with the last person. Almost in a flattering way, like, oh, this is different. And then I've seen the opposite. This isn't working. The last therapist did this and this and this with me, and I don't think this is a good fit. And I'd say, I understand that. I can look at some of those things, but the way I work is this particular way. I use elements of CBT or elements of interpersonal therapy or elements of this type of therapy, but this is the way I am. It's very much the way I'm acting with you right now. I'm not acting. This is me. I'm asking questions or responding to questions. And some people are not used to that. They'll come in and say, I used to have a therapist to be really silent the whole time. Or the worst is, I had a therapist. Is it normal for a therapist to cut their nails during their session with me? I was like, I don't typically hear of that. So self-grooming is not ideal. So sometimes it's in that way, but other times there are people that, I do better with homework. I do better with CBT that's strict and manualized. I'll say, I don't do that, but maybe you should talk to somebody, and let me give you some names of people. I just want people that come to see me to get the help that they need. And if that's not for me, that is fine.
Can you take us through some of the different modalities? You started mentioning them already, but I think it's cool to lay it out for people.
Sure. So cognitive behavioral therapy is a form of therapy that was developed at UPenn years ago. And it looks at your cognitive thoughts and your behaviors. So CBT, cognitive behavioral therapy. And you're looking at the way you think about things? Do you have automatic thoughts about things? Do you have certain distortions when you think? Do you have catastrophic thinking? So you're looking at these and you're keeping even thought records. You're starting to categorize your thoughts, understanding them. And when you understand them, then you can start to have some behavioral changes too. There's exposure response prevention therapy that can be part of CBT. So you make a hierarchy of fears. You look at the bottom rung, like what's something, let's say you're afraid of snakes. Start with that at the bottom. Let's just use the word snakes a bunch, and you monitor how you feel on an anxiety scale 1 to 10. You keep doing that till the anxiety goes down to a 2 or 3 or 4 over time, a couple of days, weeks, whatever. And when it's down consistently, then you go on to the next rung. So this can be part of CBT too for anxiety and people who have fears. So that's cognitive behavioral therapy. And I'll use elements of that in my therapy. What I do the bulk of is called psychodynamic psychotherapy, and that's looking at relationships, the dynamics between people. Oh, I noticed that this relationship you're describing with your father, it seems to mimic actually the relationship you have with your husband. Can you tell me more about that? I'm looking at what is happening in their lives and what are patterns of behavior that might still not serve you well that you're doing, or what are patterns that might be different that could serve you better. So that's psychodynamic work, looking at relationships. Psychoanalytic is looking at the unconscious. It's looking at experiences earlier in your life that you might not have realized impacted you. So I'll use some elements of psychoanalytic psychotherapy. Then there's acceptance and commitment therapy, where you're looking at, okay, I do tend to see the world this way, and I do have this understanding of it. So let me accept that, commit to possibly seeing something different or looking at it in a different way. So I use elements of all of these different therapies. Some of them are strictly manualized, meaning there's a manual. And if you are a strict person in terms of CBT, you do the 10-week, this week we do this, this week we do this, this week we do this. Some people love that. They love the homework that comes with that. They love the I guess, schedule to it. For me, I find I like to get at the root of things more, which the psychodynamic and psychoanalytic stuff helps me to see. Then I can bring in elements of CBT also.
What about DBT?
DBT, dialectical behavioral therapy, is a therapy that has the most evidence for treating borderline personality disorder or borderline traits. Borderline personality, when I first heard about it in med school, I'm like, borderline what? They either do or don't have something. But the way it was originally described is borderline, meaning is somebody on the border between psychotic, having a break from reality, and neurotic, using all their energy to maintain and hold on to their anxieties, try to manage their anxieties. So borderline traits, that's best depicted most recently on television, in my opinion, by the mother in The Bear. So Donna Berzato, played by Jamie Lee Curtis. There's some incredible scenes in The Bear where she really shows borderline traits. In the episode The Fishes, where she's cooking the Christmas dinner for everybody, she shows an unstable sense of self. She shows that she can devalue herself very quickly. There's even some suicidal type gestures, the idea that people are abandoning her, and this frantic reaction to perceived abandonment. So DBT is used to help with those types of traits and features and personality styles. And what happens in DBT is there's a very comprehensive team that looks after someone. There's a 24-hour care group. There's group therapy. There's individual therapy. There are techniques. You do things called chain analyses, for instance, like, oh, this event happened and set you off. Tell me, what was the start of that? And then what was the start of that? And then how'd that go? So there are very strict things you do.
Why is that so well suited for specifically BPD?
I think that, and it's not something I'm an expert on, so I want to be clear on that. I think that there are ways to get people to look at their behaviors that help them say, oh, maybe I don't need to respond that way. I think that's part of it. I also think, to be honest, and I remember learning this too, some of the stuff is so tedious. They're like, I don't want to do that. I'm going to change my behavior so I don't have to go through a chain analysis next time with my provider.
Right.
So I think there's that. But I also think with all these therapies, a lot of it comes down to the connection you have with people. When there's a team looking after you, you're connected to people. People are thinking about you. People want to make sure you're okay. And that's really what I find is the base foundation for psychotherapy is just being with somebody, understanding them, being curious about them. I probably ask 500 questions in my day because I want to know about people and I want to ask. And some people will say to me, well, maybe just observe. And I do that too. But there are ways to make people feel like they're important. And I think when that has not happened in someone's life, when they've not understood that they're a priority, then all kinds of dysfunction can happen in their lives.
Have there been, I know they've existed to some degree, maybe not wars is a bit of a strong word, but disagreements about is psychodynamic therapy the right approach versus CBT versus analyzing. What has shifted and what has been sort of the mainstay, if any?
What I think, and there's some studies showing this, is that it's really about the connection with the provider. No matter what modality, it's about the connection with the provider and feeling there's a relationship there. So you could do CBT or you could do psychodynamic work, and it's really the provider. So that said, there's still a belief that cognitive behavioral therapy is the gold star for people with, say, OCD or severe anxiety. And if you're not doing that, you're doing them a disservice. And I will work with people in the way I do. And if it comes to my attention that they're not improving over time and they're really still distressed, I'll say, why don't we have you try something with a CBT provider? So there's still certain beliefs about things, but it really does come down. Evidence shows it comes down to the relationship you have with your therapist.
And how does medication start playing a role into the therapy modalities with your patients?
With my patients, so a lot of psychiatrists will prescribe medication and do what's called medication management. And we, at some point I can go over how to start with a psychiatrist 101 because a lot of people get confused.
Yeah, psychologist is talk therapy, psychiatrist, usually medication, but also could be therapy as well.
Yes, psychologists have gone to graduate school. They can't prescribe medication and they can do evaluations, they can do psychotherapy, lots of stuff psychologists can do. Psychiatrists have gone to medical school and they can prescribe medication. Some people have a medication practice where they see people and they just prescribe medication. Maybe they have 15-minute slots, maybe 20, maybe 30-minute slots, and they do that back to back all day. I feel like I'm missing something if I'm not talking to the patient in psychotherapy. And so I prescribe in the context of seeing somebody in therapy. And medication, as I tell people, can be a part of treatment. We talk about when it might be indicated and what does that mean? And what are the risks? What are the benefits? What are possible side effects? What happens if you don't take medication? When we start, when are you going to stop? All those things. So we have conversations about that. But I see medicine enter the picture as a part of treatment. And I see it in particular when someone's not functioning throughout their day. They're not getting through their day the way they should.
Have you felt like over the years since you've been in practice, there's been an uptake with comfort surrounding medication or a higher reluctance to want to be on medication?
I think there are a lot of factors that play there. Some of them are, do I know people on medication, or do people get better on medication that I have heard have been on medication? So I think people want to know that there's been some success or a reason to take it. I think people get scared sometimes because they see, again, back to depictions of media, terrible side effects depicted on TV, or they see people not themselves, whatever it is that they've seen. And then there's also family and cultural values and beliefs. Like, what does it mean to be on medication? What does this do for my identity and how I see myself? Am I flawed? Am I broken? And do I need fixing? Is that why I'm taking this? So there are a lot of reasons for people to come in and be excited about medication, and a lot for them to be not so excited about it. And I haven't necessarily seen an uptick in patient acceptance. I think with younger generations, there's a lot more destigmatization of mental health that's happened over time. Older generations still feel, when I see people in their 70s, 80s, 90s, sometimes they're like kind of looking over their shoulder as they walk in the building and want to make sure that everything's okay.
Yeah. I imagine it's tough for someone who's being recommended to take a medication that we as medical providers say we don't have a perfect understanding of why or how it works. How do you manage that?
I say exactly that. We don't know exactly how this works. The studies show that the serotonin system is involved in mood regulation and an emotional response. These medications somehow affect serotonin, and it could be in the pathway itself. It could be in the receptors. It could be potentially that it increases serotonin. We're not exactly sure. That seems to have been dispelled, but some more research recently is showing this or this. So I have those conversations. I don't want to hide things from my patients. But there are a lot of people that feel better on these medications. And as soon as we're starting it, I'm thinking about when we can stop it too.
Do you ever feel like, has it ever happened that you recommend a medication to a patient? You're like, man, I know this is a good candidate. This is a great case for it. But the patient's just reluctant for cultural reasons, yes, or reasons that perhaps are not medically sound in nature. And you're very frustrated that you want to be able to help them and you know this is a potential way of helping them, what do you do in those scenarios?
I hang in there with them. I have to meet them where they are and just say, I know we've talked about this. It'll be weeks. I'll say, I really think we should try medication. There's one patient I'm thinking about in particular. It was a long time before they were willing to do that. They kept thinking, I don't want to take medication. I don't want to take medication. And then they felt better. But then they were dealing with what's it like for them to be on a medication. And we talked about that for a long time. And then they wanted to go off and symptoms came back. So we tried a different medication. So it's all part of where the person is. And if that's where they are, that's what I'm going to deal with them.
Has there been a good example in pop culture of medication or the use of medication that you thought stands out?
I have to think about that with medication. I think, actually, you know what? I just remembered. So your Friends and Neighbors on Apple TV, the main character, John Hamm's character, his sister has a bipolar disorder. And I really liked that she was not on her meds and said, I don't want to be on those meds because this particular side effect happens to me. And I hate that. So I think there are ways to talk about it. And she's also able to say, yeah, well, maybe they help me in this way, but there's this that I'm dealing with. So you see that conflict patients have sometimes. What I would say is if you're having that side effect, maybe there are other meds we can try. So there's always something else you can try.
Yeah. I think about how a single hit TV show, episode, movie can really harm our ability to practice quality help for our patients. Like we know all medications carry risks, not even medications, therapies carry risks, surgeries carry risks, vaccines carry risks. And yet if we put the focus on the scary part only and really blow up the fear of the risk, that can carry repercussions across the board. Where I remember there was, I forgot the name of the movie, I'm blanking on it now, where some very famous actor said that Merlot is trash. The wine.
Yeah. Sideways.
And as a result, Merlot sales just, again, had nothing to do with the quality of Merlot. So I think about that and I'm like, oh man, how quickly we can harm the medical system by doing something like that in modern media. At the same time, how do we allow for authenticity and encourage authenticity from people who have been hurt by these things?
Yeah, I think you can have authentic conversations. I think that can be part of a TV shows when they're going to the psychiatrist, like, well, what about this? And what about this? And actually show that real dialogue.
Yeah.
I think people would get a good idea of this is how we deal with it. And I have had some patients come in and be like, this medication, I cannot feel my groin. Like, okay, that is the wrong medication. So we should change that. And that must be really uncomfortable.
Okay.
So I think those kinds of authentic conversations in a TV show would work. You can do that.
Yeah. How do you decide, or I guess, what is your approach in discussing with a patient side effects of a specific medication when you know that discussion on its own can raise the likelihood of those side effects occurring?
I don't know that I always find that to be the case.
Really? Okay.
Really, yeah. I think just saying, hey, these are the medications. This is how it works. The science behind it is supposed to be this, or this is how we understand it. Common side effects might be the following, but before I go into that, just know not everybody gets a side effect. You might be somebody who gets none of them. Some people get some, but we don't know until we try. We're going to start at a lower dose than even usual because I just want you to get used to taking it and seeing what it's like, and then we'll increase it over time. So I think when I start out that way and people are like, okay, this might happen, this might not. And I'm saying, I don't know, let's just see, but I'll be with you as you start this. I think that can actually make people more comfortable.
So you don't see the nocebo effect?
No, I don't. I actually don't. Because I think if that were the case, my patients wouldn't go on the medications because I've talked about some wacky side effects from things too.
Right.
So I do think it's important also to dispel rumors like, so if I take this, I'm not going to start screaming in the middle of the night, am I? I'm like, if you do, that would be highly unusual. Yeah. Please let me know.
Case report. Yeah,
so, exactly. But I do think just talking about it and saying, hey, that'd be really disturbing to imagine that happening.
Yeah.
Where'd you get that idea?
Yeah, I think my mind's going to an example of like a statin, a cholesterol lowering medication, which in pop culture has been associated with muscle aches. And take me for someone in their 60s who's not having a muscle ache. That's an age group that experiences frequent muscle aches. So I always try and balance that conversation with the type of patient I'm having the discussion with, because some of my patients I'll outright say, hey, do you want to go down the list of the situations that can go wrong with this medicine? Or are we comfortable monitoring and you bringing it to me and we deciding together if this is a side effect of the medicine?
Interesting.
And it's an approach that has worked well, but I feel like could not work perfectly every time, because patients sometimes say, I don't want to know, full on, because they believe that they will have that side effect if they're aware of it, almost like they're expecting it. And that happens to me a lot surrounding pain and discomfort, where patients who are guarding, basically if they've had a low back strain and a few days go by and they say, I'm still getting up very slowly and gingerly because I want to protect the area. And they're almost like putting their antennas out to feel the pain. And it sets them in this cycle of waiting to feel the pain, and they're amplifying the pain. Versus when I say, hey, stand up. If you feel the pain, you're not going to throw your back out again. It's such a mild issue. Just go through it.
Sure.
That breaks that cycle a bit. And I wonder if this plays into that psychology of it.
Yeah, I find, again, just talking very much outright, this might happen. If this happens, you might feel this. It might go away in a few days. As you stay on the medication, you might get used to some of the stuff. If it doesn't, we'll figure it out. I think that part reassures people. Like, let's figure it out. Oh, this isn't the end all be all of anything. Oh, there's other medications. Oh, you're going to listen to me? Oh, I can talk to you between sessions and send you a message. I think people feel reassured and they're willing to try something.
How different is talk therapy in someone who's experiencing a condition like depression, major depressive disorder, generalized anxiety disorder, versus someone who's, let's say, coming to see you with schizophrenia?
So I don't specialize in psychotic disorders. I actually have a colleague who does, and I send all of the patients with psychosis to him because he specializes in that. But that does present very differently. Someone with schizophrenia, that's a psychotic illness. So there's been a break from reality, and they would be hearing things that aren't really there. They might have disordered thinking. They might have delusions. And that will really play into how you interact with someone. You can imagine if someone's already delusional and maybe suspicious, those patients in particular might have a really hard time with medication. Like, oh, wait, you're giving me something? You want me to put this in my body? What is that? So someone who's specifically trained with psychotic disorders, I always like going to that person. I know how to treat those patients, of course, and I can do that, but I don't. That same type of suspicion and worry, though, with anxious patients I have can certainly impact the treatment. Someone who's really anxious, if I make a small change or suggest a small change to something, that can trigger a huge reaction. Like, oh, I can't do this. It's the medication. And then they start looping. They'll use the word looping on this, or they'll have ruminations about medication. So it depends on what they're dealing with, but that can impact the therapy and the treatment itself.
Yeah. I'm crazy. I'm depressed. I have PTSD from that date. All the colloquial terms that people use that are actually words that have meaning in our field. Yeah. What's your take on that? How do we correct? Do we need to correct?
Well, I correct because I think it can not reassure is the wrong word. It can educate people. So when somebody says, yeah, I don't know, maybe I have a mania, I'll say, tell me why you think that. And they'll say, okay, in psychiatry, there's actually a real strict list of criteria for what mania means. I know we use it colloquially in songs or in whatever to say you're going back and forth, but that's actually not what mania is. Mania is when for 5 to 7 days you've been awake for days at a time because you have increased energy. You might be taking on more activities and your behavior might be unusual compared to what it is. You might be having sex with multiple people or starting to gamble, or your finances, you made 200 transactions. So you might be doing things that are different and you're grandiose and you think you're going to change the world and you're going to meet God and create a new language. Those are criteria for mania. They're like, oh, I don't have those.
Got it. So you're able to insert some education.
Yes.
Yeah. How do we, or do we need to discuss using those words colloquially in media or on social media?
I think so. I think it depends. If more and more people are like, oh, I'm totally manic, then
like PTSD is a common one these days.
Yeah. I do think that's worth having some corrective measures taken.
What's your general stance on that right now?
What I say to people is it sounds like you might have had something really traumatic and it is affecting you for sure. For PTSD, there's strict criteria, but that doesn't mean what you're going through isn't traumatic and we should deal with it. I'm not going to treat you because this diagnostic criteria is met. I'm going to treat you because you're here in front of me and this is what you're going through. So tell me about it. What was that like? It sounds awful if you want to talk about it, or let's find a time when you feel comfortable in the future talking about it. I'm not going to push you, but it sounds like something has really bothered you.
Speaking of traumas, what's your take on the book, The Body Keeps the Score?
I think that I haven't read the whole book, so start with that. I think your body does remember things, and people who've had traumatic experiences can find themselves remembering those experiences. Flashbacks are different than memories. It's you feel like in the moment you are back where you were before. So I think it's important to talk about what are the criteria of PTSD? What are you experiencing when you feel you are back in that kind of a moment? Your body might keep the score. Your body might have a memory. Oh, when you are touched there, that is not something that's okay. So I do think there's some truth to this idea that our bodies react to trauma physically and emotionally.
Have you seen within some of your patients emotional or mental health symptoms start taking a toll on their physical body?
Yes, and I'm imagining you see this in patients too. Somatic symptoms are when elements of mental health issues present as physical symptoms. And it does not mean, I want to be very clear about this, it does not mean the pain is not real. It means that when you experience pain, you might also have it exacerbated by mental health issues. So when I have patients with chronic pain, they'll tell me, oh, this pain is acting up. So I know that's a sign that I'm actually more anxious. And so we can talk about the anxiety as opposed to talking about the physical pain. They understand that. And they'll tell me, yeah, I definitely see a correlation. So I can see and do see physical symptoms as a result of emotional symptoms, but it's very important to make sure the patient doesn't think you think they're not having real pain.
Yeah. How do you, what's the reception like from patients on that?
They feel like they're understood, that they can hear that. Like this pain won't go away, even though they've been, say, at a neurologist or 2 primary care doctors or a bunch of people and evaluated, and they say there's no root cause. We can't see anything. Pain is pain. It's what somebody's experiencing. So a lot of times they'll say, I am experiencing this. I'm not faking this. It's like, I'm not thinking you are faking it. I'm really not.
I wonder if it's perhaps different for you because they're coming to see you already accepting of the fact, or at least open to the fact that they're discussing their mental health. But when they're coming to see their primary care doctor for an elbow pain and their mental health is brought up, I face a lot of reluctance.
I'm sure you do. and that I've seen before. My colleagues in your field and in internal medicine, I think it's really in the art of how you do it. Say, we've gone through a lot of the physical tests. There's nothing physical. I do wonder if you're a person who experiences physical pain as a result of some emotional things too. And maybe it's worth talking to somebody about that. I don't think you're crazy, to use that word. I think you're really in pain and we want to get to the bottom of it. We've exhausted these outlets. Why don't you see a psychiatrist and see if there's something there?
When a person is having a struggle, whether it's physical pain related or let's say mental health related for this example, who should they reach out to first? There's so many options these days from a social worker perspective, life coach, therapist, psychiatrist. What should one do?
First thing I think is just starting to accept you want to talk to somebody or get some help. If you have a primary care doctor, I would start there and just say, hey, this is going on and I've been feeling this way and I don't know what to do. So hopefully the doctor can give some guidance. Because a lot of times people say, I don't know, do I start with a psychiatrist? Do I start, how do I know? And I'll tell people, a psychiatrist can prescribe medications. If you think medication might be a part of your treatment, like, well, how will I know? And I'll say, that's a good question. So why don't we have you just try to start with finding someone you're comfortable talking to? Are finances a concern? Do you have insurance? What will you be paying out of pocket? So really looking at all the factors that have to go in. It's an ugly world when you think about it that way, but there's a huge range of what people charge. And some people have what's called a sliding scale and some people don't. And you find out what your insurance covers. Is someone in your network, meaning that your insurance company is contracted with that provider to allow that provider to give services to people with that insurance? That's a lot easier. That's when you pay a copay, a small fee for going, and that's it. Or is the psychiatrist out of network? Do you have to pay them out of pocket? And at the end of the month, they give you a bill that shows you've paid, and then you could submit that to your insurance for what's called out of network reimbursement. saying, do you have out-of-network reimbursement? Will they cover any of that? I have some patients that get like 15% of their bill covered by their insurance, and others get 95. So it really depends on your insurance. So really understanding, okay, what do I have to work with? What are the financial obligations that I will have? And then I say, call people, email them, ask them if you can talk to them on the phone and understand how they work. Do they have an introductory session? Do they charge for that? Do they have a 15-minute session on the phone they don't charge for? Just ask a lot of questions. Don't be afraid.
What are those good questions to ask?
What we were just saying. So how do you start out practicing? Do you meet somebody and what if it's not a good fit? Or do you have any particular way of working? If, say, somebody's heard about CBT or something, you wouldn't necessarily want to go to somebody who does dialectical behavioral therapy if you're looking for CBT. So I think asking people, how do you practice? But probably the best way is it possible to meet you and see if it's a good fit? And do you charge for that? That's a great way to start. Also knowing as a provider, does the person coming to you have a preference for a man or a woman? That's the other thing. So if you're a patient considering seeing someone in mental health, do you want to work with a male provider or do you want to work with a female provider? That narrows down the field. That's one flowchart direction for sure. Do you want to see somebody that can prescribe medication? Because if that's an option, you don't want to go to somebody else. That's called split treatment. When you have one person for therapy and then you see a psychiatrist or your primary care doctor for prescribing medications. So do you want that or do you want the convenience of seeing one person? Psychiatrists can often be on the higher end of fees because they've gone to medical school. And I think the rates that they're reimbursed, I know this in fact, the rates psychiatrists are reimbursed by insurance is very low. So typically a lot of psychiatrists don't take insurance. So you should know if you go see a psychiatrist, you might end up paying more than you would if you see somebody else. So just having all this stuff in mind and asking questions is really important.
If you're seeing a psychologist, is there ever a world where they say, we think you may be a good candidate for medications?
Absolutely. That's how a lot of people who have a psychiatry medication practice get referrals. They know therapists. Therapists say, I think this patient could benefit from medication. Can you do a medication consultation? Can you meet the patient? Now, in that case, the consultation is not as long as necessarily 3 or 4 meetings. It's often maybe 1 hour, 2 hours. It depends on how people practice. But then you would meet that person for follow-ups that are, say, 15 minutes, 20 minutes, 30 minutes. Your therapist is still the primary person you see. But there should be a good collaboration between the two. And psychiatrists are notorious for not calling back therapists. I was always taught, call back the therapist. So as soon as I finished with a patient back in residency, when I was treating them for meds only, I'd call the therapist, say, just saw so-and-so, they look okay. Let me know if you have any questions. And you'd be shocked how many people are like, you're the only person that called me about this. So
yeah, like I like to be the quarterback of my patient's care as a primary care doctor. So when I send a patient to a subspecialist, I'm doing it in the sense of you know something that I don't know because it's a very complex case, or you do a procedure that I cannot do or have the equipment to do. So I expect to get some sort of report or at least a chart message, something to know what is the plan, so that me and the patient can meet again and discuss it. And that is a dying art these days of having that level of communication. So.
I actually really like that when I am working with other providers because I like collaboration. This person sees this aspect of the patient. And sometimes I'll even say to a patient, can I have consent to talk to your doctor? And I'll say, how would you feel about me meeting your partner? Because maybe that would help. It sounds like there's a lot of stuff going on between the two of you, and I get a different perspective from that person. So the more perspectives I can have, whether from a relationship that they have with their partner or providers, I think it's good. It's helpful.
So we talked about the different varieties of mental health help you can get. What about these online BetterHelps? Are you a fan?
Yes and no. I think online therapy can be helpful. Maybe I'm old school, but I feel like the connection you have with a person in the room can't be beat. I think that I see the way somebody's tapping their legs and I can say, are you nervous? Or it seems like you're tapping your leg. Maybe just make that observation. Or I could say, I noticed when I said this earlier, you kind of winced. And so making observations that AI can't, and that can open up doors that AI can't. At the same time, I have had some very anxious patients, and some of them have told me, in between our sessions, I've asked AI this or I've asked AI that. Whether that's good or bad is arguable, because I think it's good that they can seek something in between, but it might perpetuate seeking reassurance, which is something you're trying to help someone anxious not do. I think in the future, what's going to happen is AI is going to be a base level of care, and then it's going to go up from that. And maybe the most expensive care is going to be seeing a person in person.
Got it. So that's in the AI space. What I meant with the BetterHelp specific analogy or question is they have, I don't know if they have therapists, they have some kind of online virtual person that you could meet with, and perhaps it's a different person each week. And it's like one of these platforms where you get zoomed in to a visit. Do you like that approach in general?
Sure.
Or?
So the reason I answered as I did too is I thought that was mostly texting. There are some sites, and I could be confused with BetterHelp.
Yeah.
There are some sites that are just texting therapy. That's where I think you miss some things. I think any connection to get people to mental health providers is good, but people often have not been in therapy before. So I would say if you're on a Zoom session where you've been zoomed in because of this program, do you feel comfortable with that person? What does it feel like? And if you don't feel comfortable, bring it up with the provider. That's the other thing I really want to see happen. So I think it can be great, but if it doesn't feel right to the person, don't feel like you have to keep doing this therapy. So use that as a way to get to somebody else.
Yeah, I always think about this from a perspective in my world where there are companies where you can basically self-diagnose yourself and get a prescription for whatever you want. And maybe I'm exaggerating when I say whatever you want, but you could say, oh, I have male pattern baldness, so I need finasteride. I have erectile dysfunction, so I need Viagra. And even as far as I have strep throat, so I want amoxicillin or penicillin, what have you.
Yeah.
So I like that these websites offer access to people who perhaps don't have access due to transportation barriers, cost, because they're usually a little cheaper than actually going to see a doctor in person. That should tell you a lot. And the fact that perhaps they can get a prescription virtually sent over to them, and it's easier to get the medication than delivered, especially if traveling is difficult for them. But at the same time, I'm like, are we hurting that alliance between doctors and patients and all the other benefits that come with a patient coming into my practice? Because if they come in and they start asking about erectile dysfunction medications, perhaps that's an early sign of heart disease, diabetes, that we now catch a condition in its early stages where it's much more treatable, or we could get the biggest impact on their life versus, oh yeah, here's some Viagra and I'm never going to check what your sugar level is. So does that function the same in the psychological space?
I hope that people don't go online to get their psych meds, because while I agree with all those benefits of it, there can be side effects, and there's also things to follow up with. So if you're on certain medications, you might want to check an EKG every now and then, or you might want to check your lipids, a blood sugar, things like that. Are you following up with that? Is someone who's prescribing this doing that? I've had a patient tell me he's gotten some meds, a GLP-1 online, and I'll say, do you ever talk to that doctor? Like, nope. Like, do you ever get any follow-up? Nope. I'm like, okay. So I think in psychiatry, no, because medication is a piece of treatment, but there's also a time when it might be appropriate to stop it. Is anybody paying attention to that? And again, a huge piece of psychiatry is the relationship. So who do you have a relationship with? I think you'll get better on that medication if you're actually seeing somebody at the same time.
What about some of these reality shows that are actually showing what therapy's like? Couples therapy.
Yeah, I think that can be good. Just realize not every therapist is going to practice that way. So if you go to somebody thinking, well, this is not how it's done on TV, it's probably not how it's done on the TV, because that's a different person and they have their own style. So I do think it's interesting to show that, and maybe it doesn't scare people. Maybe it actually makes it more accessible. Like, oh, that's what that would be like. And also, I do think it's brave of the people on those shows to allow their lives to be broadcast in some way. My understanding with couples therapy, while I haven't watched it, is people are talking about real issues that they have. And that's not easy to open up about anywhere, let alone with a camera and then shown to millions of people. Yeah,
I've seen this also play out in the podcast sphere, where similarly they have these interviews, these sessions, and then they play clips of them. And I'm like, oh my God, if we think about all the, like, to me, that takes away your frame ideology to some degree.
Well, that would have to be clarified right away. Like, look, we're going to have this medium where people are going to know your stuff. So I just want to say that's going to be unusual for the kind of treatment that we have. And I see some professional athletes, and sometimes I'll have to say, the organization that you guys are playing for, they have a certain way of going about this. The way I go about my practice might not mesh with that, but I'm going to treat you the way I treat any other patient. But just so you know, this might come up, and I will go to bat for you, and I will make sure that I explain why I'm doing what I'm doing. But this is probably going to come up. So I think if you address all that stuff up front, it's fine. But it is. I wouldn't want somebody in on my therapy. Like I wouldn't. But again, the idea that you can show this is what a therapist looks like. This is a real therapist. This is a licensed therapist who's not totally doing crazy things. That's good.
Yeah. Where do you stand on psychiatrists or psychologists who have their own psychiatric issues?
I think you wouldn't be human if you didn't have your own issues. I think that psychologists, providers, primary care doctors, everybody should know where your issues start and stop and where your patients start and stop. And you can be a better provider in mental health in particular when you're a patient yourself. So understanding what it's like to be in the other chair, literally and figuratively, to be vulnerable, to have feelings that you don't want to share or that are hard for you. So you know what it's like for the person you're sitting across from. So I think it's really important. Now, if the provider's issues are toxic to the therapy, that's a problem. Meaning, let's say they're really narcissistic and they need you to praise them. Like, is the therapy for the patient anymore, or is it for the provider? Or if there is a substance use issue and the provider's falling asleep in the session, or the provider's very inappropriate and slurring words, things like that, that's a problem. So I think if people are dealing with their stuff, great. If people aren't, that's an issue.
I'm curious, in a scenario, this happened to my therapist, my psychologist that I was seeing, and she pointed out that she was discussing another case, again, with no details whatsoever, but the fact that someone was saying things about that happened in their life, and they were looking for reassurance that what had happened to them was terrible, but objectively, it wasn't terrible. And I don't remember the exact details of it, but when the psychologist went and told them, hey, look, what happened to you is terrible. The fact that you're feeling this way is terrible, but just so you know, that's not this. And it kind of created a conflict. The patient ended up leaving. But the psychologist said to me that if they were continuing to say that this was actually harm and this was terrible to them when it was in fact not harmful, it would have yielded a bigger problem. How do you handle discrepancies like that?
What I would say in a situation like that, from hearing from you, is I would say to the patient, clearly this has hurt you. You're telling me this is still sticking with you. There is a population of people that wouldn't have the same reaction. They might have reacted a little bit differently. I'm curious what you think about that, hearing that other people might have reacted differently. So wanting to understand more about their perspective. If they go on believing it's harmful, that would be a pattern I could point out. So if they continue to believe it's harmful and it's actually not, I would say it seems like it's really hard for you to see this differently. I wonder what that's doing for you, because when people get stuck on the same idea and keep doing the same thing again and again, they're getting something out of it that they might not be aware of psychologically. I'm curious what you get from this, or what do you feel when this is considered still terrible, when maybe other people wouldn't see it that way.
Interesting. Do you think it becomes problematic when a psychiatrist or psychologist becomes famous?
What do they do with that fame? That's what I want to know. So I feel like let's say
they do good things. They want to help patients. They're trying to educate. But does that fame then take them out of the frame?
I think it can, but I can only speak from my experience. I've had some degree of fame doing the things that I've done. Sure. And what I find is, if somebody's coming to me because they've seen me in a video, like, I want you to be my doctor, why me? Why not some doctor close to you? What is it about me? Now, maybe they say, oh, I like the way you interact with people. Sure. But if someone's just starting to take on more and more people and more patients just to make a lot of money, I think that can be problematic. Not that I have an issue with money, but are the patients the primary thoughtful concern you have? And I think that should be it. When it's not the patients, that's a problem. Then go off and do whatever it is you want to do that's not patient related. But I think the fame of the psychiatrist, if it comes into the room, it's part of the therapy. Like, what is it about this person wanting to be treated by me? Or if they say, I saw you in a video, then I'll say, oh, what, I'm curious, what brought you from seeing the video to calling me? What was it? And if it seems like, oh, I just wanted to see your real person, I am. So I think that can be a problem. The other thing is for the psychiatrist to realize a lot of people might reach out to you as a result of this. And if people are really in distress, you have to have some way of just reacting in a blanket wide way of saying, if you're in distress, I can't give medical advice to anybody, only my patients. So please realize that if you're reaching out to me in distress, I'm concerned about you, but I can't actually follow up with you. And even if you're not in distress, I can't follow up with everybody and offer advice. And it's not because I'm being a terrible person. I just legally can't. And I'm actually focused on the patients in my practice too right now.
Yeah. I think about, I've had some guests on the show who were taking on patients for nutrition's sake, even though they weren't in the nutrition space, and they were getting all these great outcomes in their patients. And to me, I was like, well, is this just a selection bias? They're coming to see you because they read your book and they think you're awesome and that you're going to help them. Do their subjective issues go away once they're seeing the person who, quite literally, he said he could heal any condition with his diet? Don't you think like you're pre-selecting people who are almost in a cult-like fashion following your advice and will get better at higher rates than if you brought your diet to my community health center? And that person didn't quite get what I was saying, but I'm curious. Do you think that could be impacting how well the therapy is landing to a better level, but perhaps for not the right reasons? Or does that not matter at all?
I think that's where I was going. It's like, well, does it really matter? I've had some people, it's funny, years ago, I was seeing a lot more children in my patient. I still see some kids, but I was seeing a lot more. And there was one that just wanted to come because I had this one particular game. And I was saying to a colleague, I'm like, because we have this relationship in psychiatry called supervision, where you talk to somebody who's seasoned about your cases just to make sure if you have questions or issues, you can get some guidance. And I remember saying to a colleague of mine, they just want to come because I have this game. And the colleague said to me, so what? They're in your office. They keep coming back. So I think it can be fine that they keep coming back for whatever reason. And
they were saying that because they were getting help, not because they're like, oh, you got another patient.
Exactly. They were getting, they were like, they're coming back.
Yeah.
So I do think that there can be that idea of a placebo effect. Like, okay, this medication is going to help me. It's helped so many people, or this doctor seems to know what he's doing, so he can help me. I will do my best, or that doctor might do their best. It may or may not help. But if they feel like, okay, I'm getting really good care, that's also important to feel like you're getting good care.
Yeah, I try and check that, almost like saying check my privilege in that regard when I see a patient who recognizes me from social media and perhaps are way more attentive and listening or making lifestyle changes because they're aware of what I do and they're like, oh, I trust you way more than I would just any other physician, which shouldn't be the case. But is it bad that they're trusting me more, or is it going to lead them to make healthier lifestyle changes?
I was going to say, if you take advantage of it, everybody has, how should I say this? A friend of mine, I was talking about this too. She was saying to me, what's your platform? What are you using that for? And I think if you can use it for good like that, maybe people will listen to you more, and you can use that for good. It's not like you're telling people, hey, make sure you take this pink Himalayan salt. Yeah, exactly. Make sure you take that pink Himalayan salt, and you're not giving them the information that's not true or evidence-based. So the same thing, like if I can, anybody with fame, if they can use that message to help people, great. But if you're being a huckster, shame on you. Let's not do that.
Yeah. The movie Good Will Hunting is one of my favorite movies. I was just having a podcast the other day debating on whether or not it was a good movie. I can't believe I was having that debate with another Dr.Mike. And I loved the Robin Williams character who gave Matt Damon's character therapy. Thoughts on the movie, thoughts on the visualization of the therapy that was given?
Yeah, I really liked aspects of Good Will Hunting. I think there was some stuff that was done very, very well.
What specifically?
I think that showing a patient first of all, Will Hunting's character came from a severely traumatic background. Seeing his hesitation to connect with people and seeing how Sean Maguire, Robin Williams' character, helped him figure that out over time was really cool. Like, that is what is supposed to happen, is you recognize how you might be doing the same thing again and again and pushing people away. And then you realize why you're doing it, and maybe you don't have to do it. So I really like that. What I found very interesting, and you might know this being a fan of the movie, is Robin Williams improvised a few things, more than a few things in that movie. The famous, my wife woke the dog up with a fart in the middle of the night, was improvised by him. And even the Matt Damon, you can see him laughing genuinely there in the movie. And another couple of things that he did, he improvised. Psychiatry and therapy is kind of like improvisation too. And I think people respond to that movie because it felt so genuine. Robin Williams was so genuine in that movie. And that is what a good therapy can look like. You have a genuine provider, genuinely concerned about this person. I always laugh at the scene where Will Hunting is meeting all these psychiatrists and therapists and kind of poking at them all and getting them to say, I'm not going to work with you. He makes a comment about the artwork Sean has in the office that his wife has done. And he realizes, here's a soft spot. And so Robin Williams' character grabs him almost by the neck, puts his hands on him. That wouldn't happen in therapy. In fact, there'd probably be legal consequences. There were probably all kinds of things. But what I like is in the next session, when they do come, Robin Williams, he apologizes. And often I'll talk to patients, and my therapist will talk to me about this in life when I see people, they have big issues with their kids or other people. There's going to be rupture in your life. It's about the repair. And Robin Williams did a really good job of, this is the repair. I'm sorry, that shouldn't have happened. So I really like those moments. And I like how you start to see Will do things a little differently. I love the psychological parallels. He's hiding from people. He's been so hurt, doesn't want to be hurt. He's hiding as a janitor. And when he starts to solve the second problem that Professor Lambeau puts on the board, he's still kind of in the distance. He's running away. He runs away from that. So I like how that's brought up later. So these experiences the person has in real life show certain thoughts they have about themselves. I should be hidden. I don't want to connect to people. The one thing that in that movie I find funny too is the "It's Not Your Fault" scene, the famous scene. Breakthroughs in therapy don't necessarily look like that. They can. There can be a lot of tears, but it's not necessarily going to look like that. But again, the self-disclosure that he made allowed for a closeness. The closeness that he has with the therapist, I really like. That's why I said again, because the importance of that relationship is emphasized in the movie. I like how Will Hunting is there and Robin Williams tells him, I gave up my ticket to the Game 6, the World Series. And he's like, really? So there was something to learn from that. I gave it up because it was important to me to connect with this person, this wife. I had to see about a girl. And so Will Hunting can understand that. So you can self-disclose to help the patient, not for him to say, oh, I'm so sorry you missed the game. That must have been terrible. So there are a lot of aspects of this movie that I really have liked.
Do you think he shared too much of his personal life? Perhaps maybe not with that line, because that was so for the patient, but talking about his father being a mean drunk or any of these other aspects. Like, is it ever too far to start sharing aspects of traumas that you've had?
That's debatable. I think in the movie, there's insight that the doctor, that Sean Maguire has into Will that allows him to know that's okay to share. And that comes from knowing your patient. If you're just sharing that willy-nilly with somebody, I think that's not helpful for the patient. But if I've gotten to know a patient and their issues over time, I might say, when I only reveal something about myself when I think it can be helpful. So I feel compelled to tell you that I had this experience and it really made me see things differently because I think it can help them see something differently. So I don't think he overshared in that case. If he started to go into, and then I cried, and then I was in my bed for this many days, I did this, then it becomes more about him. But when you share enough, so it's for the patient to grab onto and do something with for themselves, that's enough.
What about from just the aspect of creating empathy and fostering that connection? Frequently, if someone has lost a parent or in kind of a similar but very disconnected form of loss or grief, a professional athlete that got injured and can no longer play their sport of choice, I tell them that I too lost a parent at a young age, or I too got injured when I was on my boxing journey. And it creates a moment of, wow, okay, so this person would actually see me differently because I know about their experience. Is that valuable?
I think it is. But I don't go that detailed with a patient. I might say something like, they might say, I just lost my so-and-so. And I say, I'm terribly sorry. That sounds awful. And then they might keep talking, and I'll say something like, I know from personal experience and from seeing lots of people and seeing you, this must really hurt. Like, I leave it at that. They don't need to know which family member I lost or the details, because that becomes more about me. But in that case, there's a way to do it so that they have something that makes them see, oh, he gets it.
Yeah. Because I have to do this quite often where someone has a torn rotator cuff, a meniscus injury in their knee. And I'm like, well, you don't need surgery. That's not guaranteed. 90+% recover with physical therapy and conservative management. I have a torn rotator cuff and issues with my meniscus. And look, I'm functioning quite well. So I try to use myself as an example.
And that seems appropriate. Yeah.
But it's obviously going to be very widely different depending on what you're using that for.
Yes.
And what kind of tool.
Especially grief. I mean, everybody responds to grief differently. If you lost a loved one, for some people, they don't even acknowledge it for 6 months. Or for some people, they're angry. Others are sad. Others will tell me, am I a bad person? I don't feel sad. So my experience has nothing to do with their experience.
Yeah. Have you seen, speaking of bereavement and grief, the recent Mr. Beast video where there was a gentleman that was living in a secluded home away from family and loved ones and was trying to lose, Sam, 100 pounds? And in the midst of it, the personal trainer that they hired for him ended up dying. And they told him in the middle of this experiment, and he had a very viral reaction. I mean, over 100 million views, right, on that content now. Have you seen that?
I have not.
Oh, yeah. I would have been curious to show that to you, just to was it good to show that to the general public? Is that valuable? With all consent, obviously. He was for it. He wanted to continue on the journey.
1 month, 183 million views.
Wow.
On the long form.
Wow.
So imagine the clip version of that, what that is. So are those scenes that we need to be comfortable sharing more often, or is that something that needs to be kept private?
I think it can go both ways. Are you trying to do this gratuitously to get 183 million views in a month? Or are you actually showing this because you can show people that there's grief and people grieve? And I think there can be a good side that comes out of it. Maybe you are showing it hoping for the views, but maybe you're also doing good at the same time. But I do think that showing expression is important. Showing how connected he was to his trainer is important. Showing this was an important relationship and that you're going to grieve a relationship when it ends. I think there can be good things from that. I'm often skeptical when I see somebody just trying to get views, but again, there can be good that can come out of it.
For sure. Speaking of superheroes and villains, the Joker has been one of your hit reactions. Tell us about the Joker. What's going on in that movie with that character?
What I find interesting is that movie, Dark Knight, is one that we've talked about. Colleagues and I've talked about, and even in the most recent Joker, talked about that. But there are all these different depictions of these characters. And I find that interesting because it's almost like when I see people on different days. One day they'll come in this way, one day they'll come in that way, and they might feel this. So it depends on the depiction. But the overarching theme of the Joker is that he is really a psychopath. So a psychopath is someone who's callous and uncaring. They will use people as pawns to get what they want in their lives. They really don't care about anybody else other than that person affecting them in a way that they want. So he really is a psychopath. And he's not psychotic. Psychotic means a break from reality, hearing things, seeing things, hallucinations, delusions. He doesn't have that. Now, there may be 1 or 2 stories out there in comics from the 60s that show something like that, or 70s or 80s, but he is not a psychotic individual. He is a psychopath. So I often use that as a starting point. He doesn't really belong in Arkham Asylum, which is the universe, the Gotham City equivalent to a forensic hospital where someone would go to get treatment for their mental health issues rather than get into the criminal justice system. He belongs in Blackgate Penitentiary. He belongs in a prison because he knows what he's doing. He knows what he's doing is wrong, and he continues to do it. So he's really a psychopath, and I think people are interested always to hear about that. With villains, when it comes to villains versus heroes, villains are unpredictable. We don't know what they're going to do. We know Superman's going to do the right thing. We know Batman's never going to kill anybody. We know Wonder Woman's going to do this. we don't always know what the villains are going to do. And the Joker seems to be one of the most unpredictable.
Which depiction of the Joker was most interesting to you?
I really like the Dark Knight Heath Ledger version. And my understanding was that previous to his death, they were actually going to have him in another movie. So I really liked his depiction. He was just creepy and scary and so callous. It was like, wow, this is a scary villain from Batman. I'm glad Batman's here.
Yeah. It's been theorized and some people have debated it. Does playing a role that dark impact an individual's normal day mindset?
I don't know. And I've seen those reports too. Jack Nicholson, even back to the 89 Batman, and other people saying this was really disturbing to play. Heath Ledger dying and the drug issues, and Jared Leto, I think, said something. I think if you immerse yourself in a dark world, it certainly can affect you. There was a time when I was doing some work that involved me seeing lots of very disturbing things, and it definitely did affect me. I was like, this world is pretty horrible. And so it affected me, and I was only doing this for, maybe a year or so, a little bit more. And yeah, when you're not.
Yeah, is there some truth to the fact that when you smile, you get some of the same endorphins or neurochemical pathways start firing? And perhaps when you're exposed to that world, much like when you watch an athlete perform a task, your brain lights up as if you're performing the task, something along those lines.
Yes, just smiling can make you feel better, can make somebody else feel better. There was some recent data that when you ask someone for help, their experience of that is the same way as if you had flirted with them.
Yeah.
So there's this endorphin rush, there's this feeling, wow, I can be useful to somebody, I can be important to somebody. So yeah, all of these things I think impact your.
Do you think there are people that are out there trying to hack those mechanisms?
In what way?
I don't know, like pickup artists or con artists.
Oh, I'm sure. Whatever. Yeah. I mean, yes. If you ever read The Game was the famous book. One time, people trying to figure out how to pick up women, pick up men, whatever from that. So yes, I'm sure. And con artists prey upon, and cult leaders even, to prey upon people who have psychological needs and feel like, okay, I can give this person a purpose and I can give them jobs. Now I'll cut them off from the rest of their family and create this space in their lives just for me. So yes, people do try to prey on what people need.
Yeah. Do you see in this world of preying on what people need any miracle snake oil promises to your patients that piss you off? Maybe you seem pretty level-headed. You don't get pissed off.
Yeah, I try not to. I do. I save that for my own therapy. But I think whenever anybody's saying this is going to cure everything, this is going to cure everybody, I'm very suspicious.
What about the word cure in psychiatry?
So cure, that's a great question. What does cure mean? Does it mean you no longer meet criteria for this diagnosis? That could be. But what I often tell people, because they'll come into my office and they'll say, I want to leave all this behind. I don't want to deal with this ever again. And the conversation I frequently have with people is, I think we need to look at it differently. This is always going to be a part of you. It is always going to be painful when you think about this. How do we help you move along with it? So is that the cure? You learn how to move along with these things and you know how to dial down the volume like it's a radio knob. Like it's always going to be there. Just do we know how to mute it? Do we know how to get it so it's not affecting everything? So I think cure is really kind of an interesting thing.
Mm-hmm. And you were saying that there's some people that claim to have cures?
Yeah, I mean, I've seen like this diet will help you. Maybe it will, but it's not going to cure this or that.
Are you thinking of the recent research surrounding keto diet?
No, keto diet actually I have seen help. It's keto diet. There's evidence. There's evidence. Sure. Again, if there's evidence behind these things, I'm absolutely for it. So there's keto diet suggesting it's beneficial for people on seizures that have had seizures even, and is protective against that. I think that there can be improved mood with vitamin D. It's not going to cure depression, but it might improve your mood. Maybe it's a piece of something else. Although I have had a patient say, yeah, my mood did go, I no longer had depressive symptoms with vitamin D. It doesn't mean that everybody needs to take vitamin D in that.
Sure.
So I think that's the thing to think about.
So there are no like specific supplements out there that are like, this is your mental health supplement. And
I haven't seen that. No. And usually I'll tell people, the issue I have with supplements is you don't always know what's in them because they're not FDA regulated. But there can be supplements that we can use. That there's supplements they add to something. So if you take a supplement, magnesium might help people feel calmer. That's certainly one. L-theanine is another one. Maybe it helps with sleep. So all of these are supplements, but they're not going to necessarily do everything. And when I see something like this will cure all depression, like, I don't know about that.
Yeah. Something stuck in the back of my mind when you were defining the word psychopath. I feel like listeners or viewers might hear your definition of that and be like, oh, I dated one of those.
Yeah.
Is that...
I've been asked this before. So the psychopath term means essentially people say you were born that way. Sociopath, we used to say, means over time society created and morphed you into that. We kind of use them interchangeably now, is really psychopathic or sociopathic, and it doesn't necessarily mean you're born that way or society created you that way. There's an idea that a sociopath adapted to that behavior because it helped them survive in the world around them. When it comes to dating, psychopathy is probably an extreme version of narcissism. One of the traits for narcissistic personality disorder is you lack empathy. So an extreme version would be, say, Ted Bundy or a serial killer or something like that. So I think when people are talking about that, they're talking about extreme narcissists. And I want to understand, well, what's going on? I want to start helping people. And I see a lot of people dating. I have patients in California, New York, Florida. I see a lot of people dating different places, different ages. And we'll talk about people they're dating and say, oh, do you feel like any of that's concerning? And so sometimes this stuff comes up. Whether they're a sociopath or not, I don't know. But if they're doing things that are pretty harmful to you, maybe it's not the right fit. So let's forget about labels.
Yeah.
Let's just think about what's going on here.
Yeah, because I mean, if you just search the word narcissist on TikTok or something, you're going to get a lot of dating stories.
Yes.
You'll see two individuals from the same relationship labeling one another the same traits. So
sure.
It's interesting how you could see it from both sides.
Yeah. But it's just like you asked about other language, bipolar and mania. There's specific criteria if you're talking in a psychiatric sense, psychological sense of narcissism. I think they're talking about people who are totally absorbed with themselves, not considering other people, think they deserve the best treatment. They should be the center of attention. They're pursuing unlimited power, beauty, money, whatever. Those are narcissistic traits. And maybe you are seeing them in people you date. Are you displaying them also? Or what's happening? So
makes sense. What do you think primary care doctors should do better when it comes to mental health?
What I would love to see more of is I'd love to see psychiatrists and primary care doctors talking more and saying, this is how you might ask about this. I'd love to see primary care doctors say, are you having any thoughts of suicide? Are you having any thoughts of harming yourself? And following up with those questions too. I'd love to see them not leading the patient in answers. Like, are you having any of this? Like, not nodding their head, but like just ask the question and then see what patients are saying. It doesn't have to all be forms. That's one way to do it. But
like the PHQ 9s, CAT 7s, you don't like those?
No, I like them, but I'm saying it doesn't have to be only that. Like if you look at it and it's low score, I'd still ask your patients. Say, I noticed on here you wrote these things down. Just want to check, have you been feeling lately? Just asking that question. Now, I understand the reasons primary care doctors don't. Limited amount of time, huge amount of patients. But I think maybe asking things like that, how have you been feeling lately mood-wise? I do see now in primary care offices, which I really like, I think they're going in this direction, the person initially taking vitals, the nurse or an NP or whomever it is, will say, how are things at home? Having any concerns about safety at home? Similarly, they would ask, how's your mood? Are you having any depressive
they do
thoughts?
Like a PHQ-2 or
something
a shortened
like that.
version.
So,
and then intimate partner violence, obviously.
Exactly.
Screening is something that we do.
So I honestly think keep continuing to do that, maybe add more detail if you're noticing something with the patient. Don't just rely on the form. If you see something with the patient, ask more. And then also don't be afraid to reach out to your mental health colleagues. Be like, hey, I'm concerned about this. Asking men about eating issues would be great.
Tell me more.
Saying things like, how much are you eating? What are you eating? What does a typical day look like? Because there are eating disorders that are presenting in men, restricting food and trying to sculpt their bodies in a certain way, teenage boys in particular. So I would ask about that for teenage boys. I think that would be important. I think also asking, quite frankly, asking about porn, online, things like that. Like how much time are you spending watching the internet? How much time is spent?
Is that a growing issue in patients?
Yes. Yeah.
In what way?
I think a couple ways. Teenage boys and girls, exposure to porn at earlier ages, looking at it, not really understanding at that age what it is. I think it can be an addiction for men in particular, same for women, but I tend to see more men with that issue. It can also get in the way of realistic expectations. sexually with partners, that they want their partner to do certain things I see in videos. Or I've had a ton of people that are dating in my practice tell me, yeah, when I'm with these people sexually, they all need porn to get off. And I want to be with somebody that doesn't need that. Or they'll say things like, yeah, they have these crazy ideas and they want to do things that I want no part of. So I'm having to tell people, okay, when you're dating, maybe you should set some ground rules with your patients. Set some ground rules with your partner. Say things like, all right, look, no hitting, no biting, no spitting, and I don't want any derogatory language. Sure. So asking people actually about these things, I think, is becoming more and more important.
In terms of partner communication, do you ever do partner therapy, group therapy, or couple therapy?
Couples therapy is one of my favorite things to do.
Oh, really? Why is that?
Yeah, I think it's so interesting to have two people who at some point, and hopefully still, love each other and are really having a hard time understanding each other, because inevitably what I see is they're going through things that are very similar to each other and they're not knowing how to talk about it. And I want to give space for them to understand each other in ways they never have before, and to talk about each other and think about each other in ways they have not even considered. Trying to point out that while you're seeing your husband having a tantrum, let's figure out what he's actually feeling in the moment. And then he can say things like, I feel totally alone. I feel totally disconnected. And then being able to say to the partner, do you hear what your husband's saying? He feels totally disconnected to you. Yes, you're seeing all this childish behavior. And no, that is not a good way to get your partner to want to go back to you. But can you see that he just feels totally alone?
Here's a very interesting question. I'm going to phrase it the way that I am purposefully. Is a good outcome of couples therapy ever that the couple separates?
Yes, I think so. If they're doing so much damage to each other.
But amicably. Like that it was, oh, wow, this went great. This person's awesome, but we realize we're not right for each other.
I think
Does
so.
that happen?
Yeah. I mean, I think if for them it feels right, if for their kids, if they have kids, it is right. Why is it wrong? Because I wanted them to stay together?
Well, no, in the sense of like, does that actually happen, or is that some fairy tale that I'm
I think there are times when people come in and say, look, I've had people call me, we're going to get divorced. We want to know how to do it in a way that's going to help our kids and not hurt them. So I think sometimes they come to me with that idea, or they get referred to me with that idea. It's often when I see people, they really do want to stay together. If it's really contentious, I'll say, all right, you need to stop, wait, and then it gets a little bit more heated, and that's hard. Or with families, because you asked about not just couples, but I see families and groups. When I'm seeing a kid, I sometimes have to sit with the parents. Now, if the parents are together, I'll meet with them and talk to them about their kid. If they're divorced, I will try to meet them separately, because what use is it to put them together? But what I'll do is I'll say things like, okay, I spent about 10 minutes with you. If your child who lives with you feels any degree of discomfort the way I feel after spending 10 minutes with you, there's really a problem, because I feel completely ignored and your child lives with you. So I just wonder if you're really ignoring them. So I think in those moments when there's more than one person in the room, I really like that there's different dynamics, and I could point out to them, look, right now what's going on is you're saying this, you're not even hearing this person, and you're saying this, and he's not even hearing you. So we need to figure out what's happening. So it's the idea of, all right, let's work together. Because I think they've missed feeling work together in a while. What's
the right way, or what's the optimal way to get divorced so that it impacts children less? And is that even possible?
I think that the teaching has always been how the parents communicate during and after the divorce is most important.
To each other?
The kids, yes, to each other. So if you're horrific to each other, that is going to impact your children much worse than if you can be civil and if you can be amicable. And that takes some restraint. So if that means you limit the amount of time you have with your partner, fine. But I think that was what we were taught impacts the kids. Because otherwise it's incredibly stressful for the kids. And I've had some people say, I'm thinking about divorce. I'm really concerned about my kid. And what I'll say is, I'm not pushing you into this marriage. I'm not pushing you out of this marriage. We should talk about it. I will tell you that with kids, if it's a very toxic environment when you're with your partner and you get divorced, the time with your child may be even more meaningful to all of you.
That's powerful.
It can be.
Yeah, because that's not even a thought in people's minds. They automatically assume divorce is the worst outcome for their child.
Yeah.
It might not be.
It might not be. It might not be. It really depends on many factors. And I'm not advocating for divorce. I'm not saying it's not good.
Yeah.
I want to be clear. But I think that it's important that people realize, is your relationship with your kid affected because of this relationship you have with a partner? And if so, can you change that? Or are there other issues here that are just too difficult? And in that case, maybe your relationship would get better.
That's so interesting. What do you think the most misunderstood part of therapy and psychiatry as a whole is?
I don't know if this is a misunderstanding, but one of the things that I find, I'm laughing because I will see people, they'll come in and be like, they'll talk and they'll be like, all right, so how long do I have to do this? And then,
like there's a deadline.
Yeah, I'm like, okay, so therapy is a slow burn. You're not going to necessarily feel like you're in another place in 6 weeks. It takes time. You might, hopefully you will, but it's going to take some time for you to really make a lot of the changes. You're going up against often decades of things. So there are people in my practice that I've seen for a decade or longer, and hopefully that doesn't mean I'm a terrible doctor. Hopefully it means that they're still getting something out of this relationship. So I think one, it's that. Two, an understanding I hope people can have is that most of therapy happens outside of the office. You have that hour, 2 hours, 3 hours, 4 hours, depending on how often you're seeing your therapist, with them in the office. But what is sticking with you outside? How are you thinking about what you left with when you were talking to your therapist? So I think that's another thing to realize, and that there aren't always breakthrough moments, and it doesn't look like Good Will Hunting all the time.
Yeah.
So I think that's important. Not that that did a disservice, but it's not that you're going to come in and feel like you're super connected. It's going to take some time. It's going to take some time to figure out what it is you're trying to work on too.
Do you ever have patients who come in and say, look, I'm not interested in talk therapy. Medication is what I need. Fix it.
Yes. So typically I'll talk to them on the phone and say, are you looking for therapy? Are you considering medication? It says pretty clearly on my website, I do therapy-based practice. But if they do that, I'll say, look, I don't do that, but I can offer you these people's names. I might also say, if I'm talking to them on the phone for 15 minutes, I might also say, it sounds like while you're looking for medication, there might be a lot for you to talk about. I wonder if it's worth you coming in just to see what it's like. So that's another way to do it. But I will refer them to just psychopharmacologists if that's what they're looking for.
What's your favorite movie that has had a hint of psychiatry in it?
I actually will say, I think that most recently the TV show, not a movie, but the TV show, The Bear, I really like the elements of psychology and psychiatry in that. I think it shows so many things really well. As I mentioned earlier, Jamie Lee Curtis, the character she plays, Donna Borzato, has alcoholism, has borderline traits, has histrionic traits, and the impact she has had on her children, who are adults in the show, is so true to life, that they had to always look out for her, that there was no room for them, that they were shaped because of her actions. That, I think, is incredible. I really like Jamie Lee Curtis's portrayal. I think that's awesome. Other things that I think have been recent, I do like, as I mentioned, Your Friends and Neighbors. I like the way that there's this idea of bipolar disorder and people come off their medications and they don't like their medication. I think there's elements in different things.
What about for kids?
For kids, that's a good question. The Never Have I Ever for teenagers, I thought was good, showing a therapist and an adolescent interacting. I thought that was really good.
What about adolescence?
The show on Netflix?
Yeah.
I thought that was good. That was, I don't know if people knew the language of that, but that was a forensic evaluation of that kid. And if you remember, the female provider that went in to evaluate him did an amazing job acting and also did a great job portraying forensic psychiatry. And she wasn't keeping things confidential. This was all going to go in a report. And the way that kid was getting angry at her, I've had forensic evaluations where, forensic meaning the intersection of mental health and legal issues. I've had them where people are not happy. They suddenly stop talking. I really liked how much emotion came up in there. I think that was really well done. And the toxic male culture that they talked about outside of just the forensic evaluation, it's very true. I mean, a lot of that is swallowing the red pill or whatever color pill you want to use.
Sure.
There's all kinds of stuff there, and I'm glad it's being addressed.
Yeah. And I know you're working on some projects regarding media. Tell us what you can share about some of those projects.
Well, right now I am working on a screenplay on a pilot for a TV show that deals with psychiatry and hospital work and patients and the providers. I'm also doing more media work where I'm consulting with video games, TV shows, films. People are asking me, can you give your input on this? I want to make sure I don't do anything stigmatizing. This needs more depth. So those things are things that I've been working on. And then also just trying to do more of this, getting out, talking to other providers that I like and admire and who have a big audience to reach about mental health and not to be afraid of it.
Right. And before we started talking on camera, you mentioned you're an author of some interesting books. Tell us about that.
So I wrote some medical humor books with some colleagues, some friends, also doctors. There was that old series of advertisements you might remember on TV. 9 out of 10 doctors recommend this. 9 out of 10 doctors recommend this. And I always thought, what happened to that one other doctor? What was that guy doing? So we wrote a book called 1 out of 10 Doctors Recommends, Unusual Medical Research, Remedies, and Recommendations, and looked at historically what were some unusual things like drinking urine, using potatoes to stop bleeding, those kinds of things.
And did any of them show any medical promise? Or is drinking urine not great?
Yeah, actually, there's a coagulant in a potato. I wouldn't necessarily, if you're bleeding out, you're probably not going to shove a potato in there. And then also some weird stories like a potato inserted in the vagina after childbirth because it would stop the bleeding, but you leave it in too long, it also sprouts. So just looking at things like that.
Interesting.
That was one book. And then another book I wrote a long time ago, I wrote it under a pseudonym, scrambled all the letters in my name and came up with Rich E. Dreeben. And it was
very Batman.
Yeah.
Joker.
Yeah, exactly. There's a urban legend that actually happens in the ER where patients come in, you might be familiar with this, and they have complained of stomach pain and they'll say, oh, it really hurts. I don't know why it happened. And then you're doing your evaluation. Did you travel anywhere? Did you eat anything unusual? Did you injure yourself? Did you fall? No. Then you do an image and turns out there's something inserted in the rectum. So I wrote a book called Stuck Up, 100 Objects Inserted and Ingested in Places They Shouldn't Be. And we have x-ray images that we owned and were able to get possession of and showed some of these things.
Just to highlight the variety that is the human.
Yeah, I think, and honestly, we didn't do any harm to patients. Patients were all okay with sharing. It's the idea, nobody's named. It's the idea that laughter sometimes is the best medicine, and to be able to laugh at ourselves is really important. Now, obviously, those patients weren't laughing at the time.
Of course.
But it's just the idea that, wow, this is kind of absurd. And the way that people go about trying to pleasure themselves in some ways is interesting. But I do think that I learned from my patients a lot. And that's the other thing. Just to go back to something you asked about Good Will Hunting, what I really liked in there was that the provider, Sean, learned a ton from his patient about himself, and he could apply these things to himself. And that's something that happens in psychiatry is I am constantly learning from my patients. One guy asked me once, he's like, do you ever get anything out of talking to me? I'm like, of course I do. So there's this idea that it's just about the patient. I've really emphasized that with you. But I do learn a ton from my patients. I understand worlds in ways I wouldn't before. I understand how someone who's completely different from me goes through experiences. And I really liked how that was done in the show, in the movie. And I really like that from seeing patients, I could write books and do this kind of work.
What kind of personality, because we have individuals who are med interested, perhaps psych interested, and they say, I can imagine myself doing this. What kind of personality or characteristic fits best in your line of work?
I don't know if there's a personality type. I think if you can be empathetic, if you're able to understand yourself and tolerate yourself and your own emotions, know what those are so that you can be in a position to help somebody else with that. I think that's
so you need a high level of self-control and regulation.
High EQ, I think, a high emotional quotient. Yes, I would say that would be best. But if you don't have that, there are other ways you could practice psychiatry. But I do think if you're going to do therapy, you really need to be able to sit with somebody. And that can be really painful, really painful. If you're sitting with somebody who's just lost a child, if you're sitting with somebody who's, dealing with all kinds of pain, just to be able to sit with that, it can be really hard. And then to realize, and I'm still learning this, my therapist is often telling me this, sometimes just being with someone is enough. Like just sitting there. Mm-hmm. I'm always thinking, what do I do? What do I say? Sometimes you don't have to. It's just a matter of just being quiet, sitting.
If you were having someone shadow you as a med student or pre-med, and they're interested in your field, and you sense they tell you they have a low EQ, do you discourage them?
Not at all. Even though I said a high EQ would be great, I would say, well, tell me about that. Let's figure that out. What's going on here? And when I do teach med students, I will first of all ask them, how do you learn best? Do you want questions? How do you like this? So I'm trying to meet them and understand them. And then oftentimes if somebody has a low EQ, it might be because emotions were never okay in their family. So we got to figure that out. And when someone actually starts to get in touch with their own emotions, that might open up the door of like, whoa, this is really helpful. Let me go into psychiatry.
It's almost like you're doing a session with your students.
Yeah, exactly. So you got to figure out why, what's holding you back. And actually that's something I want to touch on in the pilot that I'm writing is what is holding somebody back from that.
And 32 hours a week can be compassionate fatiguing. Do you ever experience compassion fatigue? Is it reasonable to expect to have compassion fatigue? It's hard to, like if you're seeing multiple patients in a day and they're all telling you about loss and grieving, that's got to be heavy, no?
It can be heavy. I think of it a couple ways. And I was lucky at my med school to give the speech at graduation. I was voted by my classmates to give a speech, and I talked about it then. It's such a privilege to sit with patients and to be able to understand them. And in psychiatry especially, you're talking to people in their most intimate moments. They're sad, they're happy, they're married, they're divorced, they've lost somebody, they've sold their company, they've created a business, they're a household name now, all those things. They made a professional team. So I find it a privilege, and I always remember that. And that helps me with any kind of compassion fatigue. It's like, I get to do this, and they're choosing to do this with me. They could choose anybody that's in the mental health world, and they've chosen me. So that helps me. The thing I get most fatigued with is not so much compassion. It's more the focus for 50 minutes on somebody. Because I have 50-minute sessions. Some therapists do 45. And when you have a number of those back to back, it's like, whoa, I gotta make sure in the middle of the day I have a break just to be able to reset. And I don't save enough room sometimes for people at the end of the day. So if I finish 8, 9, 10 sessions and someone says to me, how was your day? I'm like, oh, it's fine. That's all I say. Like, that's it. And we move on to the next thing. So I think that's really tiring just to be able to do that.
What is your way of resetting?
I find exercise incredibly important for me. So I will work out 4 times a week with weights, and then other days do other things. I like to bake when I can. I find that important. Fiction, reading, watching television or something that I can do like that. I really like just being with family, my immediate family. The family creation that I have is really rejuvenating. So I find that a lot of fun.
Is there, like, I know I get a benefit of it, my patients do, watching mindless TV shows that you know are garbage.
Yeah.
But like for some reason, because they're garbage, makes them watchable?
Yes, and I won't name the shows, but I have a tendency to watch some of those. It's because, in my opinion, there's something on in the background. You don't have to tune into anything
deeply.
But it can still be there. It's like white noise in the background.
Got it.
And I think it can let you be alone with your thoughts in some way without maybe feeling completely alone. I do think that there's a predictability to that, to the reality shows, to the baking shows, the competition shows, the whatever shows you're doing and watching. There's something formulaic about them. Those procedurals, in an hour, everything's wrapped up. It's amazing. It's like, oh, it's a nice, neat bow, whereas people's lives are not nice and neat. It takes a lot longer than an hour. And also, when you're seeing so much heavy stuff during the day, at the end of the day, to know like, oh, this person can't find their
true love.
Yeah, whatever. Oh,
perfect match on Love Island.
Oh, they lost a shoe. Great. So I think there's something comforting too in seeing people have issues that really aren't that big of a deal, or sometimes watching movies where you see people have really big deals and you can look at your life and be like, oh, it's not as bad as that. Yeah.
Like I used to, when I was younger, in maybe my late teens, early 20s, loved watching hard-hitting dramas, serious bits of movie. And then like now I come home after a long day and there's like, oh, best drama award. I'm like, God, I can't watch a sad drama. Like, where are the silly, stupid comedies?
Exactly. Yeah, it's the same thing. My wife will always want to watch something sad. I'm like, nope, not gonna watch that. She's like, what about this? Nope, not gonna watch that. I'm like, I have had enough nonfiction. I need fiction. So,
yeah, I felt that in watching The Pit, the first episode. I was like, oh, this is too real right now.
Yeah. I actually really enjoyed The Pit. I felt like, and I saw your take on it too. They finally did it right. The psychiatry elements, I think they They did it right in a way that made people mad, but that's what they should feel about the way mental health is sometimes done in the hospital. Like the Kraken was this guy who was given this name of a monster. He was going to wake up and pee on somebody.
Yeah.
And I think that is the way a lot of times in medical ERs, patients that are psychiatric patients are looked at. So it is terrible, but it's also true that that's how that's looked at. And there was a comment made to one of the characters in the show. I think it was Mo, like, you can go into psychiatry. But it was almost cutting like, you should get out of this. You know, and I think that is accurate. The way people in medicine might look at psychiatry and the way it's looked down upon. And I think they really captured that. So I don't think that's necessarily a flaw of the show. That's a problem with how we see mental health.
Yeah. Yeah, big time. Did you read House of God?
Yes.
Yeah, Samuel Shem. It's there is a truth to it, a brutal reality that's not sexy and not talked about. But there is, like, in taking care of sick people, it takes a toll on the human mind and body. And there are weird coping mechanisms that people don't get, like the dark humor at nursing stations.
Yes.
People don't get that.
No, absolutely. They don't get the dark humor, and that happens. And I had a colleague who ran an ER during COVID, and the way people came together, the way it felt like the city was coming together, it's very true. So the Pit did a great job with that. I didn't find that too much like work. I think in part because it's been so long since I was in a medical ER. I worked in a psych ER for a while.
Got it.
But I did think, wow, they really got it.
Was there
right.
ever a show that made you feel that?
Oh, yeah. The show on HBO, In Treatment, from years ago, the one with Gabriel Byrne, that was like coming home from work.
Yeah.
He was a therapist. Yeah, and the Monday shows had a Monday patient, and the show, the Tuesday patient. I'm like, this is work. I don't want to do this. And sometimes there'll be stuff, where couples are fighting, or parents are not being great with their kids. I'm like, I don't need to see any more of this.
You're like, here's what I would tell them.
Yeah, exactly. And I've been asked that. Like, okay, so if you were the psychiatrist on this show, what would you say? So yeah,
that's great. Where can people follow along your journey?
If they go to drericbender.com, all spelled out, DoctorEricBender, drericbender.com. That's my website. That has lots of videos.
Why'd you choose to do doctor spelled out?
I think because
I did it too. That's why I'm asking.
Yeah, that's good. I don't recall exactly. Maybe because it just felt weird to me not to have the period, DR period.
Oh, okay.
So I don't know if that was it, but I chose that one that people could see me there. I have a YouTube channel. I haven't done videos on there in a while, but what's there, I'd love people to look at because it's about shows that are still on.
Yeah.
And looking at Yellow Jackets, looking at Ted Lasso, which is coming back for season 4. It was looking at some other shows too, including Euphoria. That show made me feel like work was in front of me, and I wanted zero to do with it because not that it was bad. It was like all these teenagers behaving badly. And for a while I had some really difficult cases where teens were doing bad stuff, but also there's a lack of mental health care. And that also reflects real life.
Yeah.
Where are the child psychiatrists? Yeah. But that show made it hard. But you could see all those videos on YouTube. My cool. There, I think I am Dr. Bender.
Okay, there you go. I did it because there were too many other Mics.
Oh, that makes sense.
To distinguish myself, I guess, somewhat. Well, thank you for the work that you're doing. Thank you for this awesome conversation. I definitely feel more enlightened. I really am excited to see medical dramas in the psychiatric and psychological space just do better.
Yeah, me too. Thank you so much. I admire what you do, and it's been awesome to be part of it. Thanks very much.
Thank you. Injuries happen in real life and in video games. Click here to check that out. And as always, stay happy and healthy.
Everyone was calling me to help them with videos.
Okay.
And I become famous in the university because everyone was like, yeah, just call Cristo. He acts for free. He likes it and he's good.
Say hola to Cristo Fernandez, who you may know as the iconic Danny Rojas from Ted Lasso on Apple TV. Cristo's performance in Ted Lasso is quite memorable, not only because of his iconic catchphrase,
"Football is life,"
but because he did all his own stunts on the pitch. How is he so convincing? Because Cristo isn't just an actor, but a former professional soccer player from Mexico. His story is fascinating. From playing pro soccer to losing it all after a devastating knee injury, to selling life insurance, studying acting in the UK, and now voicing Wheeljack in the new Transformers Rise of the Beasts. Cristo not only has a face for the movies, but a story for them too. Football is life. But now, is acting life?
I think both forever football, but yeah, acting and filmmaking. are life, but also life is life.
I feel like being in both worlds, you have a very good sense of knowing how hard it is to become a professional athlete, to work as a professional athlete, have the disappointment of a professional athlete. And now you're having that experience as a professional actor and having this huge amount of success, which obviously congratulations on. What do you think is harder, becoming a professional athlete or becoming a professional actor?
Well, thank you. But I think everything in life has its challenges.
Sure.
I just think that I learned so much from my experience as an athlete, yes, and I embracing and using some of those skills that I had there, and I apply them in my new activities that I have now. Yeah, like
what?
Like the hard work, the discipline. I think somehow the worlds are similar in that sense, and like I remember, like training every day, and playing football every day, and like in my things I do now, like I also do all of those things, like writing. I write every day too. So I think that mentality that I had as an athlete, I put it on to work now in my acting and my filmmaking. But also I learned from my mistakes as well. Like I think I didn't have the mentality that I have nowadays. So I take now more care of the way I think, and probably if I had that mentality back then when I was an athlete, things might have been different.
Really?
But everything happens for a reason, and as you said, like I touched bottom when I had my injuries. I lost my contract, and I was on my way to the first division. I was training with the first team.
Wow.
But also I think everything happens for a reason. I don't think that injury just happened because it was bad luck. I just think everything, it's like all those thoughts you put out there in the universe.
Take me through, because when I looked online, I couldn't find sort of details on your injury. What happened? How did you injure your knee?
Well, I had two injuries in my two knees, in the left and the right. The first one was in the left, which was the big one, and that stopped me a little bit longer. And it was in the moment I was training with the first team and everything. It was both the meniscus, but the first time also the meniscus and a little bit of the patella.
Patella tendon.
I lost a little bit of cartilage there. I'm great. I recovered, and as you guys can see in the Tesla, so I can I do all my stunts proudly, honoring my football career.
Okay.
But
so are you saying you personally killed a dog when you did the penalty?
No, that's important to mention. No animals or dogs got hurt or damaged in the process of Ted Lasso.
You know, I also played football growing up.
Football, American football?
No.
Football, soccer?
Yeah, soccer. In high school, I was actually the captain of my soccer team.
Ah, nice.
So it was a passion of mine as well, not nearly as serious as you took the sport and how successful you were at it. But I found that in the United States, obviously there's a lot of Spanish people that play in the US in parks and games and things like that. I found that when I played with Mexican players specifically, it was a lot more rough, the games. Do you experience that being a Mexican soccer player?
Well, in Latin America, we are tougher.
Yeah, but it's like the slide tackles are dirtier. I don't know if holds true, and I'm just stereotyping here. But I specifically was always worried that I'm like, oh, I gotta watch my knee.
Also, we are very passionate by nature.
Yes.
So I think that's true. Like, football is a religion for us,
of course,
and so I can see that. Yes.
Do you contribute any of that passion from other players or perhaps tackles or whatever affecting your injury? Is that partially what caused the injury, or did it happen non-contact?
No, it was an accident. It was I was running to defend, and then 3 actually 3 teammates, we collapsed.
Oh, okay.
And actually I think I was running to defend. I was not looking, and probably the other guys didn't, and boom. And I just remember like I blinked for, I think I probably passed out, probably my only time in life that I passed.
Really?
Yeah, but it was just a couple of seconds, but I don't even know. I just remember I was like, and I never liked lying down. I just tried to stand up quickly. And as soon as we stood up,
You went to the fall.
I felt like there was something wrong with my knee because I was losing balance. And that's when I was like, okay, yeah, I cannot go back.
Yeah.
And then, that's how it happened.
That's brutal, especially with your own teammates. Well, unavoidable, obviously. Like you can't control an accident. And it's
Yeah.
interesting that you say that it was meant to be because it was like really outside of your control, outside of your teammates' control. So it's quite true in that sense of things.
Yeah, but again, reflecting on life, and I was adding too much pressure probably to me because I was on my way there.
Were you a midfielder coming back to defend?
Yeah. I played right, left, midfield.
Okay.
Was good at running lots.
Yeah, a lot of running.
And crossing the ball, and I was fast. I had lots of skills with the ball too.
Okay, so you had those injuries and they set you back in your career. How did you decide to say, okay, well now I'm shifting from professional athlete to life insurance salesman to be able to reach the goal of becoming an actor?
Well, so like when I finished high school, because my professional football career started when I was 15. So high school I did it at nights, and then I didn't do anything else after high school, only football, and then. But I always wanted to do stuff, so I joined languages, and also, which is I think when my artistic bug started to bother me, because there was I had some spare time. And there was like a music school near my house that I always saw it there, and because I was only doing football and the languages, I was like, I'll join the half hour there, and I just joined like a bit of guitar and piano and singing, and I've been always in the world of sports with my friends, and when they saw that, they were like, you want to sing and music, and I was like, I just have some killing time. But then my parents told me, study something, just please us with that, because my parents they liked studying, and I was like, okay, whatever. And then I joined the career of communication, and at the beginning I was the worst student, but the teachers loved me because football is a religion back home, and that's the guy who plays.
Yes.
Give him a 10, and I was like, yeah. And even though I was sometimes getting late and missing, I was the worst. But then the injury happened at the same time where I was watching some classes like journalism and audiovisual languages and writing, and nobody wanted to do anything in the videos. And I was the one that you should do it, and I was okay. And I started to act in that. So everyone was calling me to help them with videos. Okay. And I become famous in the university because everyone was like, yeah, just call Cristo. He acts for free. He likes it and he's good. Yeah. And I was like, okay. So I ended up having like a portfolio of videos, like from shitty videos to a bit more better videos.
What was the shittiest? Come on.
The shittiest, I mean, like there was like
did you do like some Shakespeare thing or something ridiculous?
Well, because it was communication, we had to create like these campaigns for products that we invented. So I remember I did one like a nap, like I don't even know, and I was just like, and looking at the video there, and I was just acting like a commercial, you know. I remember doing some cookies commercial, and I was just doing so many scenes and so many like short films and things, and I just loved it. And I was just doing it for free, and that's when I discovered my passion. I did a bit of theater in the university. So yeah, that's where I discovered my passion. And from there on, I was like, this is what I love. I want to do this. Let's do this. And,
so you've probably done drills as a professional athlete. I mean, you've definitely done drills as a professional athlete, but then you've also done drills as an actor. What's the hardest soccer drill or football drill, and what's the hardest acting drill that you do to practice?
Like drill, what is drill again?
Like, for example, in soccer, you would go around the cones over and over again, like a strategy to practice.
Okay,
like a short,
like exercise.
Yeah, short exercise that you do as an actor and as a football star.
Okay, as playing football, I mean, also like being in a great shape takes like, like, because the skills are always there. The game you love playing, but just getting that condition. I remember like the pre-seasons, like we go to Barranca, which is like the hill,
and you do sprints up the hill.
Yeah, and like I remember so many people throwing up, and like literally like the body collapses, and you have to find a place where you can take a shit, and like because the whole body is like collapsing just to be in the great shape.
Of course.
So it's not easy. Like, that the
okay. So the wind sprints on the hills, that's bad.
Yeah.
But what about as an actor? What exercises do you do that are hard?
As an actor, well, I mean, personally, to me, just going to the UK and just acting in another language, and just because English is my second language, Spanish and it's my language I grew up with. So I remember the first 6 months getting used to the language and the terms and Shakespeare.
Yeah.
And I was like,
oh
God, my brain is hurting. Like, it was midday and I wanted to go to bed. I actually thought for a moment there's something wrong with me. And my principal, my course leader, special shout to her, Jack Bessel at Guildford School of Acting. She kindly told me, "No, don't worry, Cristo, it's fine. You're just getting used to this language and Shakespeare and everything." And I was like, okay, yeah, you're right. I should take it easy. But I mean, just getting
the new language
and more acting wise, like the theories but to me personally, my life just just getting used to the language. And
of course that's hard. Is memorizing lines for you hard?
So at the beginning, I think that was what I was like more worried about, but as it's like anything in life, you practice,
pick it up and you're good.
Practice. It's like you give me a ball and like it goes, and like I just start kicking it.
Yeah.
Like now working, for example, in Ted Lasso, an experience I've learned is that things change so much. TV is faster than film, and where before I will be freak out and you give me a lines and I learn them, and then I go to the set and you change them, I will be like, oh my God. But now you do that and I'm more used to that.
What's your strategy for memorizing? Do you just read it multiple times? Do you have
I think writing them down.
Really?
Yeah.
Okay.
It's just rather than just reading them, if I write them down, they stuck in my head better.
Because that would be my fear too. I've tried out for some roles and I was like, so worried about memorizing.
You're also an actor?
No, the furthest thing from that. But I try to sort of do what you've done in just a very poor fashion, unlike you who've had a lot of success. I am a doctor, so I said, I'm a doctor in media. I can play a doctor on TV.
Yeah.
So I've tried some roles and it's not the same.
No, but I'm sure you can act.
No,
but
terrible.
But like I this is also an important lesson that I've learned, and because I have many friends because when you start studying and you try to find your way in life, you get worried that you spend so much time doing something. Mm-hmm. But I think on the long run, you realize that everything somehow helps in life. Mm-hmm. Like I would have never imagined football was going to come back to me in my new dreams, acting. And I think what makes me hopefully a good actor is that I've done so many things in my life, like playing football, studying communication, being a life insurance salesman, like living in different parts of the world. I played also in Puerto Rico, in different parts of Mexico.
Selling cookies and commercials.
Yes, this cookies commercial, and I work in PR, I work in photographer, and I think all of those life experiences help you to be something and find your way. And it's always good to try. If you don't try, you will never know. So if you hadn't tried,
Yeah, I tried and I learned no.
yeah, but but
least I tried,
otherwise,
yeah.
at least you tried. But otherwise, you will be in your head like
Questioning. What
questioning. Yeah, I should do this. I should do this. I should do this. And I think it's always good to try, and it's better to try and fail, and from there on you carry on for the next things. You know.
And fail might mean a choice. You know, it's not like I failed because someone told me I was bad and I said, I don't want to do this. I failed because I don't like it. I didn't enjoy the process. I thought this isn't for me, didn't match. So it was my choice to fail. If I pushed and I loved it so much, I think that there could have been a world where maybe I wouldn't be a star, but I can, you know, at least practice my craft that I enjoy. So I think that works. This is a funny question. So it must have been really easy for you to take on the role of a professional soccer player, given the fact that you were a professional soccer player. But now in Transformers, what life experience did you draw upon to play the role in Transformers? Because that's got to be harder.
Yeah, well, I mean, they chose. I'm grateful, Steven, the director, and Lorenzo and Mark and everyone at Transformers gave me the opportunity to play the first Autobot that is Latino, and that was a big responsibility to me. We found the character, but I'm grateful they allowed me to keep so many of Mexican expressions and like really having the essence of being Mexican. And when the Autobot hurts himself, he says, ay. So that was to me important. But the character is Will Jack. He's a nerd, geek. So embracing that aspect. Also, he has a bit of an ego, but also not mean. So to find that was cool to play with, and yeah, Steven is amazing. So it was cool to find it, and also for me, especially with everything I'm doing, I'm trying to bring opportunities back home to Guadalajara, where I'm from, and we recorded all the voice for my character in Guadalajara, Mexico.
Wow. Okay.
The film is shot in New York and Peru, which I haven't been. Hopefully one day we'll go there, but all the voice we recorded in my hometown.
Wow, that's really cool. What's been your relationship with health? Have you always been healthy outside of your knee injury? Do you see the same doctor all the time? Do you have a primary care doctor?
Yeah, no, sports has always been part of me, and it's still part of me. And I like, in terms of eating, I've been discovering new ways of eating. Like right now, I'm in like an intermittent fasting situation, which I think with the crazy schedules, it allows me to keep in shape too. I've also learned that, like, I've always loved doing sports and working out like crazy, like so much. But I also learned that sometimes, well, it's all about how you eat. Sometimes more than the
exercise or performance.
Than the exercise, because now if I compare the amount of exercise I do now, if I compare it to my glory days, like I exercise less now, and probably in terms of like definition and fitness, I might have better results now. But
wow.
But also I love eating, and I eat lots. Everyone who you meet that says that met me can tell you that I eat like crazy, and I've opened doors in life by just eating so much. Like I remember as a kid, like the mothers of my friends were like, "Yeah, invite Chris, so he eats a lot." And even nowadays, I go to anyone's house and they are like, and they see how much I eat, and that opens doors.
What's your favorite meal? Like if you had a last meal, what are you making as your last meal?
No, well, Mexican food is my favorite, of course.
Yeah.
But
specifically,
but you have to go to Mexico to try the real deal. Okay. And also our cuisine is so different, and it changes from Guadalajara to Mexico City to Oaxaca to the north.
So what's the meal? What's the?
Well, you have tortas ahogadas in Guadalajara, and you have a pozole. Have you tried pozole?
No, what's pozole?
Pozole is like a soup with big corn flakes. And it has chicken or meat, or it doesn't have to if you're vegetarian. That's probably my favorite. It's just good. It feels warm in the belly, and it fills you up. But like I love Japanese food. I think probably after Mexican food, it's Japanese and Chinese food too. Yeah, I have Chinese blood in my veins.
Oh, really?
Yeah.
Okay. You did the genetic testing?
No, like just the father of my grandma.
Oh, okay.
My great grandfather was from China. So I have a bit of that, and the Mexican and the cool.
Good times. Well, thank you so much for coming on. I really hope you enjoyed our conversation as much as I did. Continued success for you. We're going to be cheering you on in all your venues and ventures. Where can people follow your journey?
Oh no, thank you, Dr. Mike, and thank you to everyone listening, and thank you for the support. And in social media, I'm like Cristo Fernandez, Instagram, Twitter, Facebook, I think TikTok too, apparently.
There we go.
And also for everyone out there that wants to support me and the new projects I'm developing, my film company. It's called Doctor.MX Films. You can find it also in my profile. And so far, I've developed 3 indie films in Guadalajara, and hopefully there will be some more things coming up in LA. And I'm just trying to, as we were saying, develop more opportunities in other parts, and also for other people, because I think there are many friends of mine from Guadalajara, from London, from LA that I believe in, and then I think there are more things coming up, and doors should be open also for other friends, and also basing myself in creating my own work, which I think for anyone out there that wants to follow their dream, I think that's my advice. Just don't rely on other people giving you the opportunity. Just create it and
make it happen yourself.
Make it happen. Yeah.
And as you said earlier in our interview, it's not just football is life or acting is life. Life is life.
Life is life. Like the great song. Yes.
Brother, thank you so much for coming on. I appreciate it.
Thank you, man.
Cool. Football might be Danny Rojas' life, but my life has been medicine. Click here to hear 5 of my wildest patient stories. And as always, stay happy and healthy.